Good evening, and thanks to everyone for joining us today. On behalf of NAARI Division of Jagsonpal Pharma, we welcome you to the webinar today. This is organized by Haryana chapter of ISAR. We at Jagsonpal present to you Cystilia M. Cystilia M is formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. Do prescribe Cystilia M. We have MEMUP. MEMUP capsules contain a combination of natural progesterone 100 mg and 1 mg of estradiol as hemihydrate. Jagsonpal Pharma brings to you this US FDA and DCGI approved combination of bioidentical estradiol and bioidentical progesterone. This is in a single capsule and for the first time in India. Lycored M tablets are for male infertility. Natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage to win the race, Lycored M contains two proprietary complexes, natural lycopene as lycobeads from Israel and L-carnitine and L-tartric acid in ratio of 2:1 to give the maximum available L-carnitine as Carnipure. This is sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. To refer to this webinar again, you can visit our YouTube channel, Jagsonpal Medical Insights. Now we welcome Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR, and Director, Roots IVF at JJIMS, Bahadurgarh. Ma'am, please initiate the program.
Thank you so much. Thank you, Dr. Deepika, Dr. Jagsonpal, and I welcome you all on this Inspire Ignite series number 12. And today we have a very important session on ART Pcpndt, and we have wonderful discussions on embryo reduction and then the legality regarding surrogacy, and we have a wonderful panel discussion based on Pcpndt. And all this is with the blessings and with the support of our national ISAR. And we have our president, Dr. Amit Patki, sir, who is always behind our thinking. And sir is the medical director, Fertility Associates Mumbai. Is also a consultant at Kaur, Hinduja and Surya Hospital. And sir has, we have recently witnessed the national ISAR that was at Lucknow, with his mastermind, with Dr. Asha Bakshi's mastermind and Dr. Rajul Tyagi. It was a lovely event where there were so many international faculties and the national faculties, and it was a wonderful exchange of academic ideas and events. Sir, I think whenever Sir joins us, we will take his blessings. We have our Honorary Secretary General, Dr. Asha Bakshi, ma'am, to bless us today. She is the lead consultant at Dr. Asha Bakshi Fertility Center. She is Vice President of for West Zone of Foxy in 2022, and she is founder chairperson of the MP IAG and MP ISAR. So, ma'am, it is many thanks for joining today, and over to you to give your words of wisdom and to bless so that we can start this wonderful webinar.
Thank you, Jyoti, for the kind introduction. And first of all, I would like to congratulate your chapter for being selected for Rajatre Award. And I think you were given third prize, so heartiest congratulations. And you really deserve it, because I've witnessed your, when you were installed, the installation ceremony, and then your newspaper, and I like your logo and everything. So I think you really deserved, and well done, and keep doing the good work, because we need such active members so that ISAR can grow to bigger heights. And today this webinar is really a very important webinar, because PCPndt, we all, whatever said and done, how many times we have read it, we have heard it, and still there are certain lacunae, and then we want to confirm, oh, is it okay? So I think it's going to be a very useful webinar for all of infertility practitioners in their day-to-day practice. And I would again congratulate the whole team, you, Meenu, Dr. Jyoti, and all. And I think you should continue with your program, and all the best.
Thank you so much, ma'am. Thank you for your blessings and your words of appreciation. They really mean a lot to us. Thank you, ma'am. So today we have our conveners who have really worked hard for today's webinar, and this actually we have the Pcpndt ART committee of Haryana ISAR chapter, and the chairperson of this chapter is Dr. Manju Daga, with co-chairpersons Dr. Prabhjot, Kaur and Dr. Ritu Prabhakar. So it is the hard work and the mastermind, or say I mean, how they have created it. And mainly, I think I should congratulate Dr. Manju Daga for doing the complete workup for this whole wonderful webinar. So for many congratulations to our conveners. And we start with the first scientific session, for which I invite start with our first session. Okay. So we have Dr. Reema Goel. Welcome, Dr. Reema, as the chairperson for this session. And our speaker is Dr. Geetanjali Behl. So can we have a small PPT of Dr. Geetanjali, her CV, and Dr. Reema, if you can honor us with the introduction. Okay, we have the PPT of Dr. Manju. One second. Dr. Manju is Director of Nestling's Gynae Fertility, and she is a ASHRAE certified reproductive endoscopic surgeon who has done a diploma in advanced reproductive medicine from Germany. And she has trained from NUS Singapore and has conducted many live surgeries. Thank you, Dr. Manju. Then we have the second co-convener, Dr. Prabhjot, who is founder of the Karnal Obs Gynae Society of FOGSI. She is the scientific director of the Divine IVF and Institute for Women Reproduction, and the senior consultant at Guru Nanak Hospital, Karnal. And she has been formerly also the ex-chairperson of the Indian Fertility Society of Karnal. And then the third, the co-convener is Dr. Ritu Prabhakar, who has been the managing partner and director of the Prabhakar Hospital IVF Panipat and SR Fertility Clinic Kunli. She has more than 20 years experience and has trained conducted many IVFs for the last so many years, and she's treated thousands of couples with infertility. So welcome the chairperson and the co-chairpersons and the conveners for this conference. And now I invite Dr. Reema Goel to please introduce our speaker, Dr. Geetanjali Behl. Dr. Reema Goel is the director and secretary, is the director of Vaishnavi Nursing Home Gurugram and secretary of the MPH Gurugram. A very vibrant and a very a person who is always there at one call away and always ready to be there on any platform that is provided to her. Thank you, Dr. Reema, for joining, and over to you now.
Thank you, Dr. Jyoti, for such kind words of introduction. And hello, everyone. A very good afternoon to all of you. And I thanks to the organizing team for selecting such a good topic and inviting me here as a chairperson. Thank you all. So starting with the session, I would like to welcome Dr. Geetanjali. Can we have the CV, please? Yeah. So Dr. Geetanjali, she is a fetal medicine consultant at Medanta Hospital. She has done her fellowship in fetal medicine from Chennai, fellowship in clinical genetics from SGPGI Lucknow, and she has been former consultant fetal medicine at Fernandez Hospital, Hyderabad, and Manipal Hospital, Delhi. Her area of interest are fetal echocardiography, fetal therapy, first trimester, fetal anomaly scan, and multiple pregnancy. So welcome you, Dr. Geetanjali Behl, and we know that we'll having a very good session on embryo reduction now. So over to you.
Thank you, doctor. I'm sharing my screen. First of all, my thanks to ISAR team and Dr. Manju for inviting me for this webinar. I know this webinar is very important, and we are discussing here about the legalities and documentation of various procedures. So my talk is about fetal reduction, a wholesome approach. So my major focus will be on the documentation and counseling part. So as we know, fetal reduction is a procedure for reduction of one or more fetuses in a multiple pregnancy, and it can be divided into two types, like multifetal, which depend on the indication of the fetal reduction. One is multifetal reduction, where all the fetuses are normal, and we want to reduce one or more fetus for the better outcome of the pregnancy. And the selective reduction, where we are reducing the fetus who is having some abnormality, like structural abnormality or genetic abnormality. So normally, multifetal reduction we usually do in early gestation, like in between 12 to 16 weeks. And in infertility clinics, I know they are doing little more earlier, but as a fetal medicine, we are doing after anti-scan mostly. And selective reduction, because we know we are detecting some abnormality for evaluation. Usually we perform these selective reduction mostly like in between 18 to 23 weeks. So when we are talking about the fetal reduction, there are three basic fundamental things. The one is place and person should be registered under Pcpndt Act, and reduction on gender based is strictly prohibited. So this should be in our mind. And when we talk about fetal reduction as a whole, it has actually three components. The first one is counseling, and second one is form and formalities, and third is procedure, and all component is very, very important. So when we talk about multiple pregnancy, we know multiple pregnancy, they are associated with various maternal and fetal complications. Maternal complications like maternal hypertension, diabetes, if it is present already, then it can worsen in pregnancy, risk of APH, PPH, and operative interference. Like this in fetus also, there is increased risk of miscarriage, stillbirth, intrauterine and perinatal death, preterm deliveries and prematurity related complications, low birth weight, IUGR, and all these complications, they are very closely related to the number of fetuses. Nowadays, we are seeing that because of the new ERT rules, we are not seeing very high birth order, but triplet is very common. And chorionicity is again a very important factor in view of complications. So when we are planning for fetal reduction, there are few concerning factors which is very, very important. The first one is indication. So what is the reason for fetal reduction? Whether it is simple like a high birth order, or it is due to some maternal reason, or due to some fetal, like is there any structural abnormality or genetic abnormality. Then second most important factor is gestational age. At what gestational age we are planning for fetal reduction, whether it is in the first trimester or it is in the second or third trimester in cases of selective reduction. Type of pregnancy is very, very important, like whether it is monochorionic pregnancy or dichorionic pregnancy, because the choice of procedure will be totally different in both the conditions. And number of fetuses for reduction. So as I have already said that nowadays very high birth order we are not getting. Triplet is a common scenario. So the first component is counseling. But what we should know before counseling, there are certain factors which we should be aware of before counseling. This is a systemic review which is showing trichorionic triamniotic to dichorionic diamniotic reduction. So here we can there are some conclusions of this systemic review is the first of all, with reduction, gestational age at delivery and risk of preterm delivery is significantly improved by fetal reduction when we compare in between reduced trichorionic triamniotic versus non-reduced trichorionic triamniotic. But it will not be equivalent to the DCDA, original DCDA or singleton pregnancy. The second thing is adverse pregnancy outcome. They significantly improved because of by fetal reduction in fetal reduction group because of increase in the gestation at the time of delivery. So prematurity related complications will be significantly reduced particularly cerebral palsy. And when we compare between the reduced and non-reduced TCTA group, there is increased risk of abortion in post-FR group in comparison to non-reduced. But there is slight increase in the abortion rate in comparison to the outcome which we are getting, which improved significantly. So this is important factor which we should be aware, and it is important for counseling of the patient also. The second important fact is what is the impact of timing of reduction. So as a fetal medicine, we are doing only after NT and not before that, but it's okay because in infertility clinics, we are doing like little more earlier. But what is the advantage when we are doing it after NT? The first of all, we can actually see the detailed anatomical evaluation. In first trimester scan itself, almost 50 to 55% of abnormalities we can actually ruled out. The second thing is we can see the aneuploidy markers also, and in case if there are various aneuploidy markers are present, so suspicion of aneuploidies can also be we can remove that. If we are having some suspicion, then we can go for invasive testing instead of simple ultrasound-based NT-NB aneuploidy screening. And the third, which is the most important thing, is natural history of multiple pregnancy. The chances of spontaneous reduction in TCTA, where we are actually have seen all the three fetal heart rate, almost 17% chances are there for spontaneous reduction. So we can save one fetal reduction procedure by waiting for this period. So this is the reason why it is better to go after NT scan in my knowledge. The second period is in between 12 to 16 weeks is the optimal time because we have evaluated all the things, but we should know what is the chances of miscarriage and preterm delivery in this group. The miscarriage rate is under 5%, almost 3 to 5%, and preterm delivery rate less than 33 weeks is around 6%. But when our gestational period increased for fetal reduction, for example, more than 16 to 23 weeks, the miscarriage rate increased from 5% to 14%, and the risk of preterm delivery less than 33 weeks also increased 6 to 20%. So it's better to go with this time, but in case if selective reduction is there, then we have to see this and we have to convey this to the couple accordingly. The third thing, which is very important, impact of number of fetuses to be reduced. So when we talk about the TCTA, trichorionic triplet, trichorionic triamniotic, expectant management, so rate of miscarriage is definitely less, 3%. But on the expense of very high chance of preterm delivery, less than 34 weeks, almost 52%. But when we do the fetal reduction of one fetus from TCTA to DCDA, then chances of miscarriage is little bit increased from 3 to 7%, but risk of preterm birth less than 34 weeks is significantly reduced by 21%. So it is very important. And when we are reducing TCTA to single, which is not a common scenario, the risk of miscarriage is again increased from expectant 3% to 12%, but it will significantly improve the decreases the delivery, preterm delivery. Only risk is 10%. So these are very important facts. So when there is DCDA twin pregnancy complicated by discordant anomaly. So gestational in this group, gestational age at the time of selective reduction is the only factor which independently associated with preterm birth risk. And selective reduction is better if we are doing it less than 18 weeks, but it is not always absolute, but the chances of complications are more when we are doing it at slightly later gestation. So in late detected anomaly, there is actually again a confusion whether we should go for late second trimester abortion, reduction versus third trimester reduction. Sorry for mistake. So dilemma in decision making, there are certain scenarios where we face these dilemma. The first one is scenario is fetal reduction from twin to singleton in an uncomplicated pregnancy, which is actually it's not not absolutely contraindicated. We can do that, but we have to see the risk and benefit. Means what is the indication whether we should go for this or not. The reason is when we want to reduce from twin to singleton. So this one important thing is in uncomplicated twin pregnancy, definitely it will reduce risk of preterm delivery, but the benefit in long-term outcome is not very great. So indication should be strong. Why we want to do? The indication can be parents' choice, like their family is already completed, only they want one member, new member in their family, or there is some financial burden. Then in that case, or late age of in that case, we can proceed. Or the maternal indication, like mother is very advanced maternal age, or medical conditions like diabetes, hypertension. So in that, multiple pregnancy can actually increases the severity of all these diseases. And if there is uterine abnormality or there is history of mid-trimester abortion in earlier pregnancy, cervical incompetence is there. Fetal causes can also be there. So we have to, if there is some fetal cause, then we are actually okay because we know there is strong indication. But otherwise, if it is on the parent's choice, we have to be very careful in taking the decision. The second scenario is when there is DCTA, dichorionic triamniotic triplet pregnancy, where one monochorionic diamniotic pregnancy pair is also present. So then dilemma is what to do. Definitely from triplet, we want to reduce for better outcome, but what to do? Whether we have to reduce one singleton like reduce to singleton by reducing the monochorionic diamniotic pair. So that is actually the most appropriate choice. The reason is monochorionic diamniotic pregnancy, they are associated with certain complications which are associated with monochorionicity because of the shared placentation add on to the multiple pregnancy. The one thing. The second thing is from triplet to singleton, it will actually decreases significantly the risk of preterm delivery. But the thing is, the parents who are actually facing the infertility and they want two babies, not from triplet to single. So then it's actually a dilemma what to do. And we should discuss all these things. And the second thing is we can keep the MCDA pair, but it is not a very good approach because as I have already told you, these are actually associated with certain complication which can arise even after the fetal reduction procedure. So the ultimate outcome of pregnancy may not be as great as the first option. The third is we can reduce one twin of MCDA pair and we can keep two. But the thing is the procedure will not remain simple. It will be complicated and additional other procedures which is recommended for monochorionic pregnancy fetal reduction will be applicable. And then there will be more expenditure, expertise and availability of that facility should be there in that center. The third scenario is when we detect the anomaly late in twin pregnancy, then again we have to balance whether it is late second trimester, we should go for fetal reduction, or it should be, we can wait for like a period of maturity, lung maturity, and after that we can go for third trimester. But it is not easy and simple as it is looking. Because the thing is, the first of all, we have to see the what abnormality we have detected in the fetus. If this abnormality can actually cause preterm itself, for example, if it is anencephaly in the other fetus, then it can be associated with polyhydramnios. Then it can increase the risk of preterm itself. Then we cannot wait till third trimester. The second thing is third trimester reduction is not easy, and it is not actually same in all a part of India, because in South I have heard that I haven't done any third trimester reduction till yet. But in South, I have heard that there is no need for any permission. They can do in third trimester after reaching an appropriate time of gestation to prevent the extreme prematurity of the other healthy twin. But in our side, like in North, in Delhi and NCR, there is the requirement of permission from the board or court is there for third trimester reduction also. Although it is different from MTP, but there is requirement of that permission. So when now we will go for counseling. So counseling, it should be non-directive, explained in the language which couple can understand. So it can be local language. Person who is doing the counseling should be expert, and we should explain the risk. specific to multiple pregnancy in cases of high birth order, and risk specific to individual case. It can be maternal condition add-on. What type of chorionicity is there, that is also can be different for different type of multiple pregnancy. We should discuss both the option, fetal reduction procedure as well as no procedure, like conservative management. And we should explain the pros and cons of both procedure versus no procedure in terms of maternal risk and benefit and fetal risk and benefit. And multi-fetal reduction, what are available methods to detect aneuploidy? Because this is very important. We are doing, so that is the reason why anti-scan is very important. We can see is there any aneuploidy marker is present, like anti is fine or not, NB is fine or not. So almost anti-NB risks, ultrasound-based anti-NB risk actually give the sensitivity of almost 70%. But still can miss 30%. But if patient is okay and we are not getting any gross structural abnormality and multiple aneuploidy markers or any markers like anti-increased or absent nasal bone, then we can proceed with fetal reduction and after informing the patient. But in case if we are getting some multiple aneuploidy marker and we are having suspicion of aneuploidy in any of the fetus, then we should proceed with the invasive procedure like CVS or amnio. We should wait for that. So discuss about invasive versus non-invasive testing for aneuploidy and the benefit of the first trimester scan with anti-NB, or in case if we are suspecting something, then why we want to recommend them for invasive testing. And there is no increased risk of invasive procedure over fetal reduction complications. So that is the one most important thing. In cases of selective reduction, if we are getting any anomaly, then we have to counsel about the latest update available for that anomaly. What is the natural course of disease and treatment option available? What will be the antenatal course and follow-up in cases of continuation? What is the prognosis of the fetus and what are the postnatal management available? Impact of continuing the fetus on the healthy co-twin. All these things should be discussed with the parents in detail. Benefit, actually, whether we want to go for early preterm birth and the associated long-term morbidity, it will reduces versus risk of reduction, because we know that it increases the chances of abortion little bit more, but we know that the benefit is more than the risk. Explain the procedure, indication, option of early versus 11 to 13 weeks, as I have already explained, advantages and disadvantages of each. And the most important thing is we should discuss that there is a risk of evolving anomaly in remaining fetuses even after fetal reduction, which cannot be detectable or ruled out by this gestation. There are certain things which can appear later on. So it should be actually informed, well informed in the counseling. So now the next component is form and consent. So we know that PNDT is the prenatal diagnostic technique rules regulation. Amendment was in 1994. This is an act to provide for prohibition of sex selection before and after the conception, and for regulation of the prenatal diagnostic technique for their misuse for determination, sex determination leading to female feticide. So this is the rule which came in September 1994, and after that there was amendment and name change from PNDT to Pcpndt. Here they have included preconceptional prenatal diagnostic technique in 2002. So we all know that this is the important form G. This is the form of consent. Before any prenatal procedure or invasive procedure, usually take the consent from the patient. And here the information like patient name and husband name and address and all the things that we are explaining, we are doing the invasive procedure and all the risk and benefit we have explained to them, and signature of the pregnant woman as well as the partner we should take. And this is the doctor declaration about this, and it should be signed by and seal should be there, doctor's seal should be there. So this is the form G, which is very important. Then the next is form F. We all aware of that. F denote the fetal ultrasound, antenatal ultrasounds. This is the form for maintenance of record for prenatal diagnostic test, whether it can be non-invasive or invasive. So first column form section A is for patient detail, address, and their number of children, gender of the children, their address, phone, everything is there, last menstrual period, so that we can denote the gestational age. So all this information which should be filled up by the patient itself. And then section B is the indication, that is for indication of the doing the ultrasound or any other for ultrasound mainly. And the third section is, and then after doing the ultrasound like non-invasive, we usually write in column 14, we used to write the result of the what we have done in ultrasound. And then again, doctors sign and with seal should be there. Date and everything, each column should be filled completely. And the section C, now it is important for fetal reduction. We are talking for invasive procedure, for each and every invasive procedure, we have to fill this section C, and what is who is performing this, and what is the indication, what was the result, is there any complication, is there any we have advice for MTP or anything. Everything should be actually mentioned here in this form C. So section D actually contain the declaration from the patient that they are not, they don't want to know the gender of the baby, and it is declaration from the doctor. So all these things should be filled completely. But additionally, in fetal reduction, on our hospital letterhead, we usually take one additional consent. Whatever counseling we have done, what I have discussed earlier, like expectant versus fetal reduction, risk, benefit, and gestational age related risk of abortion, and selection of the fetus for reduction, why we are taking this, what is the indication, whether it is multifetal reduction or selective reduction, abnormality, whatever we have got, what could be the outcome if we are continuing or if we are reducing, and number of fetus or fetuses, especially in high birth order, we have to mention this, and risk of any evolving anomaly in remaining fetuses on follow-up is explained to them. Everything should be written in this in detail, and that is additional for our whatever counseling we have done, that should be described here in this additional consent, other than the PNDT. So this is the pre-operative checklist. I'm just briefly I'm discussing. Detailed scan, definitely important to rule out all the structural and aneuploidy. And we have to take one aneuploidy risk based on the ultrasound and TNB risk. And maternal blood group is very, very important here, because in cases of RH negative, there will be requirement of anti-D prophylaxis in these cases. Infection screening, very important. First trimester screening test, whether we have taken ultrasound based or is there any recommendation for invasive test, then what is the result of that invasive testing. And if patient is on any anticoagulant, we should, like heparin or ecosprin, that is very, very common in the infertility scenario, then it should be stopped at least minimum 24 hours prior to the procedure. Informed and written consent, whether it is there or not, and number of fetuses, like mapping should be there in the pictorial way, and which fetus we are planning to reduce, and how many numbers of fetuses we are planning to reduce in cases of, especially in cases of very high birth. Then chorionicity is very, very important. In case whether it is monochorionic, is there any monochorionic pair is there, so monochorionic or dichorionic, then because the choice of procedure will be different in both the scenario. Equipment I'm talking about simple for dichorionic type of fetal reduction. So equipment is same machine, but here one additional is we are taking 22 gauze long length needle, injection KCL with the 1 ml mark syringe, and injection dilocaine for local anesthesia, and all painting and draping, sterile painting and draping equipment. So this is a simple small clip for fetal reduction, how we are after painting and draping and selecting which fetus we have to reduce. So this is a long needle, and we are doing intracardiac, we are injecting intracardiac KCL here, and we watch till stop of the cardiac activity, almost 4 to 5 minutes we should actually see. And then after that, after doing the procedure, this is very important step, post procedure, documentation is very important. That fetus, reduced fetus has no cardiac activity, and the remaining fetuses are fine and having the cardiac activity, and it should be documented well, and we should actually show this to the partner also. We always call the partner inside and show them that this we have done. And again, we check after 1 or 2 hours of the procedure. We usually see that whether the cardiac activity is absent in the reduced fetus and both the fetuses are fine. Then post-procedural maternal and fetal monitoring. Again, this fetal part I have explained. Maternal, we actually look for any pain, discomfort, bleeding, or leaking PV, and we give instruction to the patient that bed rest for 3 to 4 days is required. And post-procedure advised anti-D injection, anti-D in case of RH negative pregnancy. And antibiotic is optional. Oral antibiotic we usually prescribe for 3 to 4 days. And procedure documentation is very, very important, and it should be what schematic, what we have, which fetus we have reduced, and the rest of the fetuses, position of them, because we have to follow up those in later pregnancy for their growth and other things. So it should be documented well. So this was about fetal reduction as a whole, and I hope it was good for the what we should do in counseling, and what factors are very important while we are doing the counseling, and how to document the things. Thank you.
Wonderful presentation, Dr. Geetanjali. Thank you so much. And I think you covered every aspect related to the topic. So I just wanted to know that suppose it's a twin pregnancy, and the patient is advanced age around say 39, 40 years, and after IVF she conceived, and both twins are normal going on level 1 scan at say 12-week scan. Now, so suppose the twin pregnancy, the patient wants one fetus to be reduced, and we reduce according to our judgment that everything is fine. But later on, as you said, the anomalies might develop at around 18 to 20 weeks. So how do we counsel the patient, and are there any legal implications with that?
That is the reason why I told you that we have to tell them when we are indication. Actually, we should actually evaluate carefully in these cases. We have to explain prior to the procedure that it could be the possibility whether they want to take the risk or not, because informed consent is very, very important. This is the reason why we usually include this in our consent also, written consent, detailed, whatever counseling we have done. We actually write this also in our consent form, and if they are agreeing for this, then only we go further. If we will not tell them about this, then only it will create problem. If they are aware of that and after that they are choosing, that is their decision, and they cannot actually they cannot offend on this. If we are not informing this in prior to the procedure, then they can actually create the problem. So this is the reason why we have to, even though if it is not twin, if it is any triplet for fetal reduction, then also we have to explain that whatever is the remaining fetuses, they can also get some evolving abnormality, and we have to explain this in prior to the doing the fetal reduction.
I'm asking that we have a proper printed consent, including this sentence as well, that the risks have been explained about the future anomalies.
Yeah, definitely.
Okay. And one more thing, like third trimester reduction you talked about, are there any Pcpndt related this thing also in third trimester?
No. Actually, yeah. Actually, that fetal reduction is different from MTP. So we are not actually aborting the complete pregnancy. We are doing one fetal reduction due to some abnormality. So actually, there is not a clear-cut rule present in the PNDT, but I have heard about, like in South, they are able to do it without taking any permission from the board or any court order, like in MTP, late trimester MTP. So there is not required in those states, but in our state, in Delhi, NCR, I think there is a board which from which we have to take the permission, explaining all the things, and board decide that whether we want to go with this or not. But before 24 weeks, because of amendment, we can do the fetal reduction. But then we have to think that there are high chances of preterm delivery in these cases. So we have to explain this to the couple also. So this is the
Dr.
main thing.
Geetanjali, in these cases, when we do late fetal reduction and when you guide the patient to go to the court, how you guide them to how to proceed with the permission?
No, actually, I was not. Recently, I am because I haven't done any late like third trimester reduction. So recently, I heard about this because previously I was in that we can do fetal reduction without taking any permission from anything. But recently, I've heard that like there is still requirement of taking the permission from board. So we have to actually go to the board, which is actually meant for the MTP. And we have to take the permission from that board.
And is
that
any
Dr.
condition that
Geetanjali,
the opinion of two gynecologists is required for the late reduction, or it's only one can do with the
No. In late reduction, there is it is not the requirement of two. It is actually same MTP. For like fetal reduction is not like MTP.
Yes.
so Dr.
There is some
Geetanjali,
abnormality
here
can
from the
reduce up to
medical
like
board will take permission for both termination of pregnancy as well as reduction.
as
So
well as
both
reduction.
permissions are
Yeah,
required.
as well as
Two
reduction.
gynecologists are not required.
But it is
we
not
have to
actually
approach-
uniform. It is not uniform in all over India. At some places, there is no need for permission for fetal reduction, but for MTP, it is required.
So till
And
what
who
gestational
will
age
take
can we
permission?
actually suggest the late reduction? Till what gestational age?
any
See,
age if-
lung maturity should be achieved. So like we have seen like 32 to 33 weeks also, like 30, 31, 32 weeks also. After achieving the lung maturity, then actually we are assuring that the other fetus, which is healthy fetus, in case if there is development of preterm labor, then that fetus can be like healthy after delivery. So that is the main thing. So like
And
30, 31 weeks is important. Yeah.
who will take the permission? Patient, doctor, or hospital?
Patient.
Patient. So patient will
Patient.
go to the medical board, they apply, and then they bring the
Then
permission.
they can take that. Yeah.
Okay. Okay. Do they need any letter from the gynecologist that this is required? And
Yeah. We have to give whatever we are finding is there, whatever document or like a scan is there, and what is the recommendation of treating doctor. Then they go to the like board and they show all the things. And in board also the members they decide whether the like is it
Fetal
fine to go for reduction or like MTP, whether it is we can give the permission for that or not.
And one another information for legal point of view, how you send the report to the appropriate authority of fetal reduction?
So we are sending it like we are filling the forms and we are filling the online form also, like in Form F and invasive procedure. That consent we usually take with our case sheet, written consent about the counseling and all details. But Form F and Form G we usually have for Pcpndt office. And online also we have to fill this.
Okay, suppose there is a one scenario, one twin pregnancy, and first is female baby, and now you used, and now appropriate both baby are normal, but they want only one child because they
No. Then this is the thing. This is the thing where we have to see all the things judiciously. We have to, because we don't want, if the indication is that was I was trying to tell you that indication should be like strong enough. Because we cannot, like in suspicious cases, we cannot go for reduction as per the thing until unless if there is some strong maternal indication is there, or fetal structural or genetic abnormality is there.
So
In
we have
case
to
if
be
the
very
family is
we have
in
to be
case
very careful for twins to reduce to singleton.
Yeah. This is very actually dilemma is there, and we should be very strategic in deciding for reduction in these cases.
No, so if any secondary infertility patient says, I want single after IVF, I don't want twin. So can we go easily or we should discourage them?
So in that case, they have to decide we should actually implant only single embryo in those cases. We should not actually transfer two embryos in those cases.
Yeah,
They are very
definitely.
strict.
And
In case if they want only like secondary infertility, it is not just per se their choice. We have to decide whether they are okay, because if there is some maternal indication, like mother is having very advanced maternal age, and it will actually deteriorate the maternal health condition, or if there is like financial, we can see the status, and if it previous baby, if they have previous baby and baby's gender is not female, then, because we have to be on the safer side, because these are the things which actually we have to choose judiciously in these cases. Because mostly this is not a common scenario. Common scenario is triplet to twin. If twin, they want singleton, as per their choice, we have to be. And yes, because in uncomplicated twin pregnancy, the fetal reduction will not give much benefit, because twin pregnancy can also do well. But the thing is, if it will actually harming the maternal condition, or if it is creating the financial burden over the family and previous baby is male, then we can think about that.
Okay.
Can I ask a question, Dr. Manju?
Yes.
And Dr. Geetanjali? Thank you. Thank you, doctor. Thank you so much, Dr. Geetanjali, for a very detailed presentation, very informative presentation. My question to you was that, as you appear to be an expert in the area, what would you suggest? Suppose a patient in front of you has got triplet, and at what gestation do you think is the best time for someone to go for reduction from triplet to twins? Is it 7 weeks? Is it 8-9 weeks? Is it 11 weeks? Considering the safety and everything possible, the impact on the other twins. So, what is the best time to have reduction?
The best time is when we are doing anti-scan. So that is the best time, because I have already told you that we can actually evaluate all the fetuses in detail. And if there is any structural or risk of aneuploidy, we can rule out. The second thing is the spontaneous reduction chances are very high in triplet to twin. So I just want to give the benefit, and in the natural course, if there is reduction, then we can give the benefit. The disadvantage in early reduction is actually it is not increasing the chance of abortion much in 12 to 16 weeks. It is only 5%. And chance of spontaneous reduction in triplet is around 3%. So it will not increase much. But if we are doing early, then first of all, we are not aware of that all the fetuses are healthy or not, all the embryo are healthy or not. The first thing. The second thing is maybe this spontaneous reduction is actually varies in different studies from 14 to 64%. So we are not aware that we can give the benefit to the patient or to the couple for preventing them from one procedure, invasive procedure. So that is a reason the best time is after NT. At the time of NT, they should come for detailed evaluation, and then after that we can decide and we can do the proper counseling to the couple.
Very well said.
Dr. Geetanjali, one sec. I'll just like to clarify this. Thank you, Dr. Manju. I didn't understand. So would it be between 12 to 16 weeks? Is that what you are suggesting, Dr. Geetanjali?
Yeah. Yes.
No.
Yeah, it will be like 12 to 14. 12 to 14 will be the appropriate time to go for fetal reduction.
Okay. And did you say that
when we get the NT scan and our double marker test is perfectly okay, then we go ahead so that to reduce the
one thing. Actually, I just want to interrupt.
Yeah.
Actually, in high birth order, multiple pregnancy, there is no role for double marker other than twin. There is no role for double marker. We have to go for ultrasound based NT-NB, and if we have suspicion, then at least we should wait for invasive procedure test result. At least the early QF-PCR, we should wait for it will come in 3-4 days. Then after that we can proceed for fetal reduction. That is the one thing.
So routinely we are not advising any invasive testing. Only if we have any suspicion, then we are advising, right?
We are not advising. Routinely we are not advising. If we are not getting anything in ultrasound, everything is fine, NT is fine, no aneuploidy markers are there, structurally fetus is looking fine, then chances of fetus to aneuploidy is very less. Like in low risk pregnancy.
Young patient and there is a no risk.
Low risk pregnancy.
Yeah.
So let's
thank you so much, Dr. Geetanjali.
Thank you.
Thank you, Dr. Geetanjali. Very informative and very nice talk. And thank you so much. Now we move ahead to the next topic. For that, we have our vibrant chairperson, Dr. Neeru Thakral. Please display Dr. Meenu. She is the gynecologist and fertility specialist at Cloud9 Hospital. and she is the secretary of ISAR Haryana. And I think there is no need of any further introduction about Meenu. Everyone knows. Now, next CV is Dr. Neeru. She is the director of Morpheus Thakral International IVF Center. She is vice president of Haryana Endoscopic Society, past secretary IFS Haryana chapter, clinical secretary Haryana IAG, and diploma in gynae endoscopy at CIC France. And she has a lot of experience and doing good work in IFS and in Gurgaon Obs and Gynae Society.
Thank you, Manju.
And our next chairperson, Dr. Prabhjot, now you have already listened her. And Madam is Infertility and IVF Specialist Scientific Director, Divine India IVF Institute of Human Reproduction, and Senior Consultant and Head of the Department of Guru Nanak Hospital, Karnal. So Madam has did a lot of work in this ART and law and infertility field. And now I invite Dr. Neeru to introduce our fertility live, Radhika.
Thank you, Manju. It's my indeed pleasure to invite and welcome Advocate Radhika Thapar. I think she need no introduction everywhere and especially in our Gurgaon. She has LLB, LLM diploma in intellectual property rights. So she has experience vast over 22 years in all the legal matters with over 17 years in the field of medical legal issues. Experience including but not limited to infertility, surrogacy, women, mother and child issues, rights, adoption, assisted reproductive technology, regenerative medicines, legal audit, hospital, clinical, commercial, and contractual
She's
law.
not able to join.
She is legal advisor to National ISAR in the field of assisted reproductive technology and legal secretary of INSTA. So welcome, Advocate Radhika. We all are here to listen you.
Yeah. Thank you so much, the entire ISAR team, Dr. Manju Dagar, Dr. Neeru, Dr. Prabhjot, everybody. And it's always an honor to be a part of this August forum. And now, thank you for giving me a topic which is close to my heart. My entire journey in the medical legal space started with surrogacy only, when we had a couple who were clueless. What is the paperwork? What is the legality around? And this is way back in 2007 and 8, when I started looking into, that there is a scope of law in the field of medicine also. And henceforward, everything became history because, we started doing work. Patients were blessed by all the doctors like yours with the babies, and we kept doing the legal work. Now, today, the scenario has bit changed. Today, the scenario has changed from a very liberal horizon of surrogacy in India to a very controlled horizon of surrogacy in India. I would not be saying that when people say, oh, surrogacy ban ho gayi hai, surrogacy has been prohibited. No, that is not the language, or that is not the notion that one should carry. Surrogacy has been now regulated by a legislation which is called Surrogacy Regulation Act. So basically, now we have surrogacy regulated under the Surrogacy Regulation Act. Now, this act, basically, we need to see our case criteria. Whenever you have a patient, now you can't outrightly say no. You have to see whether the patient, or a yes, you have to see whether a patient has a case for surrogacy or not. So what are the things that you need to see in that? First of all, you have to see the age criteria of the couple. The couple should not be less than, the lady should not be less than 23 years of age and more than 50 years of age. The male should not be less than 26 and more than 55 years of age. Now, this is the criteria you have to see. You don't have to see the numbers of years of marriage. I've been getting cases where people are saying, okay, abhi shaadi ko 1 year hua, and there was a law somewhere they've read that the marriage should be at least for 5 years. No, that has been taken away. Even if the marriage is 2 days old, but people have a problem like hysterectomy was done earlier, or absent uterus is there, you can straight away take that patient and go ahead for surrogacy. So so you have to first evaluate the entire case. So this I've already told. Now we are regulated by Surrogacy Regulation Act was passed in 2021. Now people can have a lot of concern why the act says Surrogacy Regulation Act 2021, and it is being passed or made applicable from the year 2022. So whenever the act is passed, it will always, that year of signing of the president or passing by the government will remain the, will always come along with that act. But it, once it gets enforced, the enforcement date will be the day when we have to start following it. We can move ahead. Then now the important thing, yes, of course we have to evaluate the case, but at the same time, are you registered as surrogacy clinic? Then only you can do surrogacy. Now most of the states are not at the moment registering the clinics, but Haryana has started doing registration. So if you are there in Gurgaon, at least get your clinic surrogacy registered, then only you can now take up a case of surrogacy. Now, under the Act, there are two different kind of clinics. One are ART clinic, one are the surrogacy clinic. If your ART clinic does not allow you to do surrogacy, get a specific license of registered as a surrogacy clinic. Another important aspect, when there is a lot of news going around, surrogacy has been stopped in India, it's prohibited, you can't do it. No. So what you can't do it, India has adopted altruistic surrogacy model and banned the commercial surrogacy. So you can't anymore do the commercial surrogacy. And what is altruistic surrogacy? That is defined in section 2B of the Act. And what is commercial surrogacy? That is defined under section 2G of the Act. Can we move ahead? Now these definitions, Dr. Manju, we have to go a little back at the definition part. So the 2B section, when we talk about the surrogacy, altruistic surrogacy definition, to read out the definition, it will not make any difference to all of you because it's all English legal jargon. Let me explain you in a very layman language that you can only pay for the well-being of the surrogate. You cannot pay for anything which tantamounts to commercial gain to her. लॉ डज नॉट प्रोहिबिट दैट कोई भी उसको पैसा मत दो. लॉ प्रोहिबिट करता है वो पैसा मत दो जो उसको कमर्शियल गेन. इट शुड नॉट बी अ मनी विच अमाउंट्स टू her getting on the business. Now let me give you a very simple example. Pregnant lady needs nutrition, pregnant lady needs care, pregnant lady has several few requirements than a normal lady. So the one for whom she's carrying, for whom she's becoming a gestational carrier, the couple needs to take care of her all her needs. And for those needs, if the couple is spending money on her, is not a commercial surrogacy. But supposingly she says, I will hand you over money only, I will do this only if you give me X amount, right? Irrespective of whether you take care of me or not, that is where commercial surrogacy is. And that is where the government has a problem with it. So we cannot do commercials. It's a simple thing. Just put a simple logic to it. Anything which is a commercial gain, paying over and above than her well-being, is a commercial surrogacy. Now we come to the other aspect of it, how surrogacy is regulated. Dr. Manju, next aspect of it. So I'll explain you this section 4, why I have specifically mentioned here. We've tried and uploaded the PDF this way, but it's not opening. Section 4 is the section which is very important. Please keep, whosoever is doing surrogacy, please see the Surrogacy Regulation Act booklet. You must keep handy at your premises. It should be on the main reception. It should be somewhere where the doctor sits regularly, does the OPD. Should be very handy, and the doctors should also be aware along with the legal consultants, because in surrogacy under section 4 it is clearly mentioned what all approvals and permissions are being granted. I know you all have a job to give babies, I know you all have a job to create babies, work on that craft more than anything else, but you all have come in a field where you all are making babies outside, right? It's not a natural, act of human beings to have their own babies. So when the facility, the IVF specialist, the gynecologist in IVF field, they're handling genetic material outside and putting in a surrogate mother, then a lot of obligations of permissions come on them, and they should be very well aware of this. So when coming back to my initial talk that you have to evaluate a case, you have to evaluate a case basis the age of the couple. So I've told you, don't take a case which is, above 50, 55 years of age. The second criteria should be that the couple should have a medical indication. Now, what is a medical indication? Along with the act, the government has passed a part of it as surrogacy regulation rules. Now, the act is a basic act which defines the rights and duties, but these rules come in handy for the officers to recognize which is a medical indication which is allowed for surrogacy or not. Now, please see, here it clearly says she has no uterus or missing uterus, abnormal uterus, hypoplastic uterus, intrauterine adhesions, thin endometrium, or small unique urinate uterus, T-shaped uterus, or if the uterus is surgically removed due to any medical condition. So this patient need not to wait. Uterus, absent uterus patients or hysterectomy done patients need not to wait for you to say कि अभी 2 साल की शादी हुई है या let the marriage to have 5 years. No, basis this indication only the government took off that 5-year clause also. No longer that clause is required. But if you have a patient who's falling on in this, now also mind this fact that thin endometrium should not be witnessed in one cycle. Okay, in one cycle if you get a thin endometrium, oh, it's a case of thin endometrium. No, watch for cycles, regular 2-3 cycles at least. Her thin endometrium should continuously come thin, and you should have done, if there is any therapy or if there is any medication you have given to the patient, despite that fact the endometrium is coming thin, then you can make out a case that this patient should be asked to go for surrogacy. Then we have the second is multiple IVF failures. Yes, so depending on 2 to 3 IVF failures, so there is a difference of opinion in some medical officers. Some says 2 are good, multiple, more than 1, they have tried twice. Some say okay, no, आपके IVF specialist ही बोलते हैं कि at least 3 बार तो try करो IVF, so depending on that. So we always say at least 2 to 3 IVF cycle failures, and then you have a case to go for surrogacy. Then we have multiple pregnancy losses resulting in unexplained medical reason. Now, understand, it's not simply a medical term, pregnancy losses. Now, you can have, people who have not taken care of their hypertension or diabetes, but if they were aware and the doctor was giving all throughout the period the medication for hypertension and diabetes also, and they were taking it also, despite that they lost the baby, then yes, whatever you could have done in that particular scenario, it was done, still the baby could not sustain. So then it become unexplained medical reason. But suppose somebody had a hypertension or a diabetes, but they did not do anything, no medical was prescribed, then the board will not give a clearance. The board will first say, okay, again try, and this time control your BP or control your hypertension with this particular medication. So this all like a cerclage ka issue, sometimes cervix cerclage, all those issues you should have tried first before you say ki now the pregnancy, even if we have done enough on the patient but can't be controlled. Then it comes any illness that makes it impossible for a woman to carry a pregnancy to viability, or pregnancy is life-threatening. So, we have CKD patients, we have cancer patients, we have now patients who have neuro issues also. And even a patient where the patient is highly hypertensive, so these kind of problems if the patient is having, it could be life-threatening, or the fetus cannot be autoimmune diseases, the fetus cannot achieve pregnancy to a viability, then that is. So these are the 4 basic category where we have to see the medical condition of the patient. And a fundamental is कानून अंधा है. You will see also हमारे वहाँ पे दिखाते हैं औरत की आंख पे पट्टी बंधी हुई, and they're holding the scales. So कहने से कुछ नहीं होगा, डॉक्टर की प्रिस्क्रिप्शन पे भी मत लिखवाइए. 3 लॉसेस थे, प्रेगनेंसी लॉसेस थे, डॉक्टर ने लिख दी, हिस्ट्री लिख दी. नो, वी नीड एविडेंस, प्रॉपर एविडेंस. इवन आपका डिस्चार्ज समरीज फॉर IVF, all this is required. And अब किसी पेशेंट को नहीं पता था इन फ्यूचर इंडिया इज गोइंग टू अडॉप्ट सच काइंड ऑफ सर्विसी लॉ दैट दे आर गोना आस्क. देयर वाज अ argument put by a patient. हमें थोड़ी ना मालूम था कि कल को the government is going to ask all these things, and we were so drained and so feeling bad about it कि हमने अपना सारा रिकॉर्ड ही फाड़ के फेंक दिया. ठीक है. So then the authorities were not listening. They said, "Dobara jao, dobara nikalwao." So I'm telling you, patient need to give proper medical record. So now comes what all approvals are required. So every patient should target to get this certificate of essentiality, and this should be given to the doctor before the doctor can do embryo transfer in surrogate. Now this certificate of essentiality can only be given first you prove your case and get a certificate of medical indication. Get your surrogate approved from the board, eligibility certificate, which will given to you also and to the surrogate mother, and then get a court order of parentage. Get all these things done, take an insurance of the surrogate, get a certificate of essentiality, and start the process of surrogacy. Now, in this, there is OCI card holders who are also allowed to do surrogacy in India, but they have to take one additional permission, which is called cert. So OCI card holders के लिए important है. You can do OCI card holders. उनको एक national अथॉरिटी से भी अप्रूवल लेना है, नेशनल बोर्ड से, सर्टिफिकेट ऑफ रिकमेंडेशन. मोस्ट ऑफ द डॉक्टर्स को आके बोलते हैं, उसमें भी थोड़ा सा टाइम लगता है टू गेट दैट ऑर्डर, बट मोस्ट ऑफ द OCI वुड से कि डॉक्टर साहब मैं इंडिया में ही तो रहता हूँ, आई हैव अ लोकल आधार ओनली, मेरे को जाना ही नहीं है कहीं, यू नो, सो मुझे तो छोड़ो ना, आई विल नॉट टेक दैट एडिशनल अप्रूवल, I'll just now do it and it get sorted. But please understand, OCI को इंडियन पासपोर्ट नहीं मिलेगा, उसको उसकी चाहे उसने जाना, द मोमेंट द चाइल्ड ट्राई टू फ्लाई आउट ऑफ इंडिया, अगर उसने 4 साल नहीं बनवाया, 5वें साल जब वो बनवाएगा अपना पासपोर्ट, दिस क्वेश्चन विल कम फॉरवर्ड of the certificate of recommendation, और तब आपने नहीं लिया होगा तो it can backfire. So please don't fall or you know for all this and tell them कि कोई बात नहीं, इसके बिना भी आप कर सकते हो. Okay. So that is where we need to see. So there is a checklist of documentation which is required by every authority. I'll explain you what is the checklist. Every stage has its own checklist. Okay. So the checklist ideally requires you to, for a medical reason, every stage will have a different set of checklist. We'll soon post it. I've already posted on the group also. You can take it. So this is the checklist. Basically, in this checklist, the government need a detailed information. You will see the first, the application, under which rule. I've stated 4 rules. You have to pin discussing with your doctor and your lawyer. You see which category you fall in. Pick that category and prepare a tabular format stating, you know, when was it diagnosed, what were the medical diagnoses, you know, what was the relevant date, what is the case summary. Case summary, you just have to put in, you know, that you were admitted, then hysterectomy was done, and then final outcome is that, you know, the uterus was removed, and then you enclose the document on which page number the document is included. This is for 14A, C and D, because here it is basically one disease based or one particular issue based. So it's like that. When you come for 14B, then medical procedure, IUI, IVF, ICSI, whatever. Now, please also understand, when you are giving as a doctor and as an opinion to a medical board, just remember they are also analyzing you. They're also seeing you, what kind of work are you doing? Are you clearly jumping? Because a question from the board comes on like this: why straight away IVF? Okay, if there is no IUI previously done. So the medical practice which is ethically done, if somebody is not conceiving, what is the first step you advise, and the second step, they are of that mindset. And if, yes, I know there are cases now that you clearly jump to IVF, then we have to have a reason behind it. That this was the reason, very low, poor AMH, or, you know, the tubes were clipped, or any reason where for that reason we need to jump to the IVF. So you should also be very clear what you are giving to your patient, and the patient should also understand that these were the procedures which were done on them. A copy of their Aadhaar card, passport, right? The government is also at times sometimes press upon the 10th pass medical, 10th pass school certificate, you know, because people have the, you know, tendency to temper with their age, because now there is an age criteria. So where they may find it suspicious, they may ask for a 10th pass certificate also. Then a marriage certificate, valid marriage certificate with the photographs of the couple. This is a stage where it is more focused on the medical bit. Here the questioning by the board is more about, you know, what you've gone through, explain it. How did that happen to you? Show us. And how would be you? Would you be genetically related? Would you be opting for donor? If you're opting for donor, then show us what is the reason you are opting for donor. And at least one patient has to be genetically related. One of the couple has to be genetically related. So it's the simplest stage. No matter whether they have a surrogate available with them or not, tell them to go and get it first, because everything is time consuming in India. Now we go to the next eligibility checklist. So now what is the eligibility? This is the toughest stage, and this is the stage which is very critical. Now why I'm saying this stage is very critical, because this is the stage where the government is going to approve your surrogate mother. So we need to put up our file very nicely, and there should not be any indication of commercial surrogacy. Hence, it's very important for you to have a lawyer with you, the one who specializes in these sort of matters, so that they know how you have to project the case, that it should not be implied by the government that there is some commercial surrogacy going on. So detailed documents require their application, their IDs. This is the couple IDs that we are talking, their marriage certificate again, and their approval from the medical board that yes, they have a case for surrogacy because as a medical indication. Then there is one criteria that the couple should not be having any child, or if they have a child, then the child is abnormal. So we have to give that affidavit to the government that we do not have a child, and if the child has an abnormality, it has to be of a chronic nature. So that kind of proof also needs to be given. Then an affidavit of the nominee also, just in case anything happens to the couple, at least one or two nominees you should mean, and try to convince the couple to give it some of their family relation. I know at the end of the day, we all sometimes feel this is a formality sort of thing, but also look from a point of view that God forbidden, if we are doing 10 cases, out of one case, there is some, patient, mishap happens. And then the friends are not going to turn up to take the baby, because we just feel like they are not sharing it with the family. They just want to keep it private. So try and counsel the patient. Then look, this is actually have some sense. So get your parents or get your siblings involved in the process. And there is no questioning, no counter questioning from the siblings or the nominee by any of the forum. So then the affidavit and undertakings or declaring that they have applied to this particular. Now different states have started taking different sort of undertakings, that they are just taking surrogacy procedure from Haryana, because now the tendency is people can enroll in Haryana, enroll in Delhi, enroll in Mumbai, and try and exploit that. Then we have the declaration that you will be taking care of the surrogate during the pregnancy, because this is an altruistic surrogacy, no agency involved. So you're personally responsible for the care. And then we have the surrogate documents. So far, surrogate ladies that we see at times don't have their study or their matriculation or their any sort of this thing. So their Aadhars are being used by the government. Then the one child they should be married. So please don't take any unmarried women as a surrogate. You can take a divorcee or a widow woman as a surrogate between age category of 25 to 35. Not a day less, not a day beyond. The moment, even if your patient already approvals, there were miscarriages, in one surrogate you can do 3 attempts. Supposingly the surrogate just turned on the 3rd attempt, turned 35 years old. You just can't do the implantation anymore. Hence, I always request a couple, try and take a lady not above 30 to 33 years. At least you have 2 years in hand. Even if she aborts in between, the doctor can give her a rest for some time before they do a reattempt with the surrogate. And similarly, her marriage certificate. Now it's very essential. Gone are the days you just check the uterus and say, okay, uterus seems fine and let's go ahead with the entire body workup, because on the doctor also to give a certificate she is medically fit to carry the surrogate as a carrier. You need to have some basis to give that certificate. So get her medical blood test done. Some doctors are even doing the chest X-ray. Then you need to have psychiatric treatment also, consultation and a certificate from the psychiatrist also required. Basis everything, then you give your fitness. Do not compromise on that. If you find the surrogate mother needs to be, reevaluated, or given some medication and then assessed, please do that accordingly. And if you have to reject the surrogate, please reject it, because don't compromise over your license. Keep all the copy of all the certificates issued by the authority to the patient in your file. And as a matter of, before you do an ET, also get an additional consent before you do an ET in the surrogate, because you've not really asked her that question. So you can ask her, okay, fine, I'm going to do an ET on you, are you okay willingly going ahead for the embryo transfer, and get it recorded. Just do these 2-3 liners that yes, she's okay with it and she hasn't posed any objection. That is where it is. And any questions from the forum, most welcome, please.
Thank you, Dr. Radhika. I think that was a very, very detailed explanation, and kind of, I think very few of us are going surrogacy. Dr. Manju, how many of us are doing surrogacy in Haryana?
Ma'am, I am not doing, but Radhika is supporting in Gurgaon to do surrogacy to our IVF specialist. So Radhika will tell us. She took the permission from the Gurgaon board, appropriate authority.
3 to 4 centers have started come up. It has started recently only. It started recently only in October, November only. The first files were put up. And gradually we are seeing the numbers are increasing. When we went first, and then we saw 2 clinics came in. Now I see 4 to 5 clinics, I think, are doing it in Gurgaon. So numbers will increase when there are positive cases, when people are,
So Radhika, one brief outline how to proceed with, and where we guide the patient to collect the document, and where we guide the doctor to collect the document, and how we proceed to the appropriate authority to take permission.
See,
just flow basically.
So basically, first the patient reaches you, or the patient reaches the lawyer. Now it has happening like this only. Sometimes the patient comes to us also directly. But I take it from the point it goes to the patient. You make a prescription of the patient. You see you go through the history, or the patient is already your patient. So you do that, and then you refer the patient to a lawyer. That's the best part, right? Because at the end of the day, लीगल सपोर्ट होनी उनके लिए, वेदर दे टुमारो ऑप्ट फॉर इट और नॉट, उनका है प्रेरोगेटिव, लेकिन आपको उनको बोलना है प्लीज टेक लीगल एडवाइस रिगार्डिंग दिस, सो दैट वो कल को आपको एक क्वेश्चन मार्क नहीं करें कि भाई मुझे तो किसी ने बताया ही नहीं, सो आप lawyer के पास आएंगे, then we start preparing the file, we see the case, we start preparing, and we lodge it with the CDHO office. The first step is the civil surgeon or CDMO, whatever, office. We file the case. Once a medical is approved, then we tell the patient कि आप surrogate लेके आइए. Now doctors पता नहीं क्यों डर रहे हैं. The point here is, for doctor it is as simple as a normal IVF. Like IVF आप अपना कर रहे थे अपने patient में, आप surrogate में करोगे. You are not supposed to take any money this way or that way in your account, which is not related to your medical practice. You've already told the patient अपने आप ले आओ surrogate. जब आपको ये तो बल्कि ज़्यादा safer हो गया. You don't have to tell the patient कि मेरी involvement होगी. आप clearly उसको बोलो when there is no text around it.
Patient will bring surrogate, but first we check the eligibility of the surrogate. That is the medical part that doctor has verified. Okay. After that verification, only the legal part comes.
Yes.
No indication. First, we have to see the indication is
medical
first is indication. That indication is so indication, and then if we proven with the proven indication, then if they bring the surrogate, then we need to verify whether eligible medically to carry the pregnancy. Conduct all fitness certificates, psychological certificate. After all these documentation, then they need legal advice.
Then they need. और या पैरेलली भी अगर उस समय तक लॉयर होगा आपके साथ में, तो उस समय तक लॉयर के पास आप उसके आधार शेयर कर सकते हो सरोगेट के साथ, सो दैट वो भी देख लें, वेरीफाई कर लें वेदर एज क्राइटेरिया मीट हो रहा है, बच्चों का क्राइटेरिया मीट हो रहा है, all those things meet हो रही हैं. जब सारा मीट होता है, then we put up the paper for surrogate approval.
Radhika, one thing, like how many embryo we can transfer? One embryo, or if the age is higher than 2 also we can transfer.
Maximum 3, but usually 1.
Yeah,
Usually
they have
one,
written usually one.
You have to justify 3 transfer,
You
but
just-
They have written in the this guideline that they one transfer we can transfer, in exceptional cases 3.
yeah,
That's what.
that is the reason. Exceptional cases you have to justify. Why?
But if age is more, we can transfer 2 also, na?
तो आप justify करो because of this
But
reason.
Radhika, do we have to take separate permission for transferring like multiple embryos, 2 or 3?
No. You don't
Does it
have
need
to take.
separate?
No. They have
Like
left
if
it on to
age is
you.
young, then you say not more than 1. What do you say?
Yeah.
Or 2 also? Like if patients say, no, I don't want to take that.
Patient.
Dr. Neeru, law says 1. If you are going for 2 or 3, you have a justification for it.
Justification.
No, but do we
इसमें तो
have to
नहीं,
justify
इसमें
and
तो-
send the document
But
to the court?
just
No,
tell
no,
me
no.
how
To
many
the-
of you are doing single embryo transfer?
No,
How
no,
many of
नहीं,
you are
this
doing?
you are asking in ART
But
ना. सरोगेट की तो एज वैसे ही यंग एज है, उसमें तो आपको क्वालिटी देखनी पड़ेगी. बैड क्वालिटी है तो आपने ज्यादा ऊपर किया उसका. जिसके आपने एक्सट्रैक्ट किए थे वो ओल्डर वुमेन थी,
तो
आपको आपका
क्वालिटी के लिए आप
मेडिकल
PGT तो नहीं कर रहे हो ना सबको. We don't know कि
No,
how
no,
many.
but according to the grading of
quality
embryo,
of
maybe
embryo,
some-
grading of embryo,
actually,
and if you are getting gametes are not very good and embryos are not very good, and if you able to justify, and if
Yeah.
surrogate is good, and at in that cycle your lining is also not good, anything.
No, but
Yeah.
are we liable to an explanation that we
Yeah,
have
liable
transferred
to
You
two
are not
embryos?
liable to an explanation, but your record should be completed while you are doing a transfer. On your transfer sheet, you need to say the reason. You have to write because your record will be audited as per law. It will you will be now
Not
soon
only,
getting health
I don't
audits.
think so, Radhika. It's not only audited later on. If there is any problem to surrogate
Yeah.
because of twin pregnancy, because of triplet, then yes, you have to be
The
answerable.
questioning will come.
for
Yeah,
that
the
thing.
questioning. Yeah.
So ये
That
कोई नहीं डालेगा like. But
Radhika, I have one question. If patient that surrogate abort, like for example, the patient they again like for cervical incompetence or they have to again go for a surrogacy board and get arranged another surrogate, or the same surrogate will be used.
No. So yes, one surrogate you can use 3 times. Now, if you feel abortion से उसका problem ऐसा हो गया, we should not be. You have to do medical analysis, right? It should not be okay for the patient to proceed with that because abortion sometimes makes someone unhealthy, unfit also internally. Then they have to change it. It's your medical advice when you see that now this candidate is no longer fit for it. If the candidate after giving a pause for some time comes out to be again fit, then you can use the same surrogate. But if you find it, you give your true medical judgment basis on what you scientifically feel, after doing scans and all that. And when they have to change, they have to change.
Okay, thank you.
And they have to take all
go to the medical board again. Then they take another surrogate again.
Yeah,
approach
not
medical
the first step of medical
Second step.
permission, but the second step.
Yeah.
Oh.
Excuse me, ma'am, I had a question. Like, how
Yeah.
much time does it usually take from the time a person approaches that they want to have a surrogate and then getting all the approvals and actually reaching up the ET?
The
Like, in
transfer.
average, an idea.
And see, every state would have its own, timelines. But considering Delhi and considering the capital, capital is taking around 6 to 8 months, right? Because every stage is taking nearly 1.5, 2 months, 1.5, 2 months. So on an average out, we feel 4, 6, 8 months could be a timeline, depending on when you get the surrogate. Sometimes people are finding it difficult to convince their families, so that kind of. So typically 4, 6 months. So you have to say the patient. Now what happens is, I'm in a lawyer profession also. Sometimes these kind of remarks. So काम बहुत जल्दी हो जाएगा. So we need to be very careful what we are telling them. We need to tell them that you need to have patience because when it comes to officer level, at times delays happen.
So in Haryana, it's taking 4 to 6 months or 2
No,
months?
in Haryana, luckily we are getting the approvals very
2 months.
fast. Yeah, you can expect even lesser than 2 months depending on how lucky we are to get the surrogate. Here the courts are taking little longer. That also I'm trying to fix it up. We have already put a first petition, but just that they are not very much aware. But I'm very hopeful once I get 1 or 2 orders from Gurgaon courts, then that will also get streamlined. So
And sometimes the
otherwise the
non-surrogate.
authority.
The centers who are not doing surrogacy, and sometimes they need to shift embryos to center for surrogacy. So it might take some time also for shifting
Yeah, so
embryos.
there are a lot of components in a case. At times the embryos are coming from somewhere. So at times like that, all we can do it, and all the patient need to have belief and trust, that there should not be delay from our end. If we are keeping holding their files and all that, that's not okay. But if we are putting our best foot forward, going whenever being asked to, filing every paperwork timely, so then rest is on the system, because all these committees, whosoever are approving, the medical board is also not single man driven. These are 3 to 4 people who sit in a board. Now they all are not specially designated officers for surrogacy. They are the ones who are looking at your beta beti ka Pcpndt. They are looking at the raids in the hospitals. They are looking at dispensing of medicines. They are also monitoring the civic amenities in some form of health. सो उसके बाद में जो टाइम मिलता है उनको एक नया एजेंडा भी दे दिया गया है सो getting all of them together on one particular date, at times one officer is available on X date, the other. So these kind of issues are there. Health laws do take time to penetrate and start giving proper results.
So in multiple previous abortions, if patient come with 2 previous abortions or 2 previous implantation failure, they can also be taken
should be good.
account.
It's Radhika, there is one question in the chat box. So Dr. Anju Yadav is asking, do we need separate permission to use donor egg, donor sperm in case of surrogacy?
Yes, we do need to mention the reason that we are taking, why the patient is wanting a donor. Can't be a complete donor embryo. Suppose the wife has a poor AMH, so we need to have the AMH report.
So we need to take permission also.
Yeah. It is written. It is written on the surrogacy certificate that they are given permission to use the donor egg or sperm, but it has to have a scientific and valid reason for it.
Either of them can be the donor, like either oocyte or sperm. Or both can also be.
No. Both can't be in
surrogacy. Not both. With the surrogate, it can only be one, either the oocyte or the sperm.
Yeah. Yes.
Otherwise, it will be as good as adoption with the.
Yes.
There is one. Okay. So sorry for interfering. There is one message from Dr. Manjunath from Birla Fertility. Sir, want to share some practical points with us. So I invite Dr. Manjunath to say.
Good evening, everybody. Thanks for giving me this opportunity. So I just wanted to share a few practical things. I've been doing surrogacy from past 2 years in Bangalore. Initially, once the law passed, there were a lot of confusion. So I had stopped surrogacy from past almost 2 years and then again restarted. Once we also got clarity, once the surrogacy cell formed, everything in Bangalore, we restarted. So few things I just, as we mentioned now, after that it amended also that one of the gamete should be from the intended couple. Both gamete cannot be from the outside. So one of the gamete should be from the intended couple. The thing is, when we select the surrogate mother, be pakka sure that do some HRT, if required, even a histoscopy, and make sure that the lining everything is fine. But once, because why we are telling is, once we approve that she's fit and they go and do affidavit, and if the lining is not coming even after 2-3 cycles, again we ask them to change the surrogate. Again they have to go to the court, make a fresh affidavit in the different surrogate, and it becomes a complicated thing. So make sure before you give the approval that okay, surrogacy is fit medically, do HRT, study the lining is good, then you approve so that they can take the affidavit on her name. Means the magistrate court permission, everything on her name. That is one thing. The second thing is, please tell clearly that to the intending couple and the surrogate that the clinician or the clinic is responsible only for the medical purpose, medical treatment. We are not going to come in between in your adjustment, whatever it's so clearly mentioned. So please clearly make sure that you clearly tell them that we, as a clinician or a clinic, are not going to come in between the intended couple and the surrogate mother, whatsoever matter, except for the clinical matters. So mention that clearly that in future the intended couple should not come and blame, oh okay, that surrogacy did that, surrogate mother ran away. All those things, headache is not our headache. It's you are what it's an altruistic surrogacy. Document that the intended couple has brought the surrogacy. We are doing only the medical part. No way concerned with any other part. No way. Even some of the agencies who are providing the surrogacy also, please don't communicate that okay, this agency is giving surrogacy, go and look for the surrogacy with this agency or something like that. At least written, don't give any phone numbers or any this thing. That's thing. The third thing is, again, as somebody was telling, if some abortion happens, everything, so they can take means they have to go for the same surrogates, they can go. But as Dr. Thakur means the Mr. Thakur told that the first part, the eligibility part, is not required to repeat, but the fresh affidavit is required if you are changing for a new surrogacy. So these are the few things which I think I wanted to share. Thank you so much.
Thank you very much, Dr. Manjunath. That was very helpful. And
I
can I make
had
a
one
comment?
query.
Can I make a comment, Dr. Thapar? Sorry, Radhika ji.
Anji, please.
Talking to, I really feel that, a lot of people approach us, we people are not doing any surrogacy. So we tend to find names, who's practicing surrogacy in Delhi, who's practicing. So we tend to give those names to the patients. And I really got this idea after this webinar, after talking to you, that it would not be entirely wrong on our part that if we judge that yes, this patient has no uterus or genuinely she requires surrogacy, we can maybe directly send the patient to you as well. There would be no harm. And I would be, I would appreciate if you could kind of share your number also on the screen before, you leave the webinar. It will be helpful, and, like people can always take your help. Like
Dr.
Yeah,
Prabhjot, in Gurgaon, so many doctors are doing, like Rubina is here, she is doing, Puneet is doing, I am doing, I think Cloud9 also are doing, so many people are doing.
Oh,
So please note Radhika's number. Whosoever
Anyone
surrogacy.
can. Many doctors are doing, because now they are helping us now. So we can take advocate help. So all
Okay, now
responsibility is
Dr.
not
Neeru, let's go ahead to the next topic. So I want to proceed with the panel discussion. So Radhika, stay here.
yeah. Yes,
Please,
I'm here only. Yeah.
Yeah, thank you, Manju, for the nice, and thank you, Dr. Radhika, Advocate
please stay
Radhika, for the nice.
for panel discussion.
Yeah, I'm here.
Okay. Okay, and now I invite Deepika, please play the slideshow. CV slide. Lakshmi, are you there?
Yes, I am there, Dr. Manju. Hanji.
Okay, then introduce.
So,
Okay.
Dr.
So
Manju, please invite the experts.
let's move on to our next session. That is the panel discussion on ART law. We have our esteemed experts for the session, Dr. Nirmal Bhasin. Can I have her CV, please?
CV, yeah.
Yes. So, Dr. Nirmal is the director and clinical embryologist and founder of Janani Fertility Center. And we have Dr. Shalini. Can I have her CV, please? Dr. Shalini is the professor of Department of Obs and Gynae of PGI Chandigarh. And Dr. Manjunath Swami, he's here with us. We've already heard him, and he's the consultant laparoscopy and fertility specialist for more than 15 years, chairperson of Karnataka chapter of ISAR, and we'll have a lot to hear from him and lot to learn from all our experts. Now we have our dynamic moderators, Dr. Rakhi Goel and Dr. Manju Dagar. Can I have a CV, please? Dr. Rakhi Goel. Dr. Rakhi Goel is the senior consultant and center head of Behl Fertility and IVF in Chandigarh. And we have Dr. Manju Dagar. Of course, we know her. We all know her. She's the director of Nestling Gynecology and Fertility Center in Gurgaon. Then we have our expert panelists. Dr. Japlin Kaur is here with us. She's the assistant professor of Obs and Gynae at B.R. Ambedkar Institute of Medical Sciences at Mohali. Then we have Dr. Jyoti Gupta with us. Dr. Jyoti Gupta is the Senior IVF Consultant at Motherhood Fertility Center, Gurgaon. Then we have Dr. Ritu Prabhakar. Thus, Dr. Ritu is the Managing Partner and Director at Prabhakar Hospital and IVF Center, Panipat. Then we have Dr. Rubina Singh with us.
And Radhika.
Yeah, Dr. Rubina is the IVF Senior IVF Specialist at Gurgaon. Then we have the advocate Radhika. We have heard her, and we have lot more to hear from her. She has experience of over 22 years in legal matters, in especially pertaining to infertility, surrogacy, women and child, and other issues pertaining to female health. And last but not the least, including me, I am the panelist for the session.
So I welcome all my experts and panelists to this session. So I'll just get to the first case maybe. A patient came, the Mrs. A is 20 years old, and Mr. B is 24 years old, and they have been married for 2 years. They have been trying to conceive, and wife has normal regular cycles, no other apparent issues, and they have done no evaluation till now. So how will we proceed? Can we do an evaluation in this case? Dr. Rubina?
Yeah, so thank you so much. Thank you, organizers. Thank you, Dr. Manju. So coming back to the question, I feel that the couple is too young for any sort of treatment. The female is only 20 years and the husband is 24 years. I think we should just leave this couple, give them time for timed intercourse, give them just do basic evaluation like sperm test or basic blood workup, and give this couple a time. Secondly, this couple is not eligible for any of the ART procedure. Anyway, she also doesn't need because she's too young. And as per this, all the investigations are also normal. So the right way to treat her is not going directly into any sort of aggressive treatment. Just give this couple time, and maybe a few more cycles of ovulation induction will be of help to her.
Okay, so we are not aiming at the, yeah.
They have done the evaluation. Ultrasound was normal, unremarkable. HSG also normal. Semen analysis normal. Sometimes we see these kinds of couples and they say that our actual age is more, the age shown in the Aadhaar card on the ID is lesser, and we have so much of family pressure. And now we have done 4 cycles of OITIC also, and they want to go ahead with IUI. So can we proceed with IUI in this case, Dr. Jyoti?
No, she's not eligible as she's only 20 years and she's not eligible for any ART procedure. So my advice to her will be let's try naturally, or she can wait till she turn 21. After that, we can try another method.
Yeah, so basically, assisted reproductive technology is defined in law as all techniques that attempt to attain a pregnancy by handling the sperm or oocyte outside the human body and transferring that gamete or embryo into the reproductive system of a woman. So IUI also comes under the ART, and the law says that clinics shall apply the ART services to a woman above the age of 21 and below the age of 50 years, and to a man above the age of 21 years and below the age of 55 years. So till she turns 21 years old, we cannot proceed with an IUI in
Any
her.
sort of treatment.
So do we give ovulation induction or not even ovulation induction also? So we are not eligible, couple is not eligible for IUI. But
The couple is eligible for treatment.
You can do ovulation
We
induction.
can do, yeah. But the couple is not eligible for IUI or any sort of ART procedure.
Oral ovulation we can prescribe.
Yeah.
Yeah.
But she has regular cycles, so maybe we should still give her some time.
Yeah, we can, yes.
Which case is that we give her some time.
Yeah. Too young to handle kids, maybe.
Yeah.
So there's a second case, 39-year-old female and 42-year male, married for 2 months. Her AMH is 0.7 nanogram per liter. Semen analysis is oligo, 4 million per ml, 20% motile and 2% normal. Trying naturally, have approached to you for IVF. Yeah. How you proceed, Dr. Lakshmi?
Yes, so since we have seen that the AMH is low for this patient and the husband also has oligoacinoteratospermia, so I will go ahead with IVF. straight away because of the so many factors there. And yeah.
Is couple fall in the definition of infertility? So,
So
1 year unprotected,
yeah,
yes.
1 year. But of course, if a medical condition which is preventing a couple from conception,
Yes.
so in that definition, of course, definitely it falls. So I can straight away go in for IVF without any delay.
So very nice.
Basically,
So
you should be able to prove medically that your patient required IVF even if they have not been trying for 1 year.
Right. So proper documentation is very important, that we are going for IVF in view of oligoacinoteratozoospermia, age factor, and the AMH. So all the
Yes.
factors, right.
Other proven medical condition include all these factors in this case. So we can go ahead with IVF.
So a patient approached us, 30-year-old female, 32-year-old male. They have been known for weeks. The parameters were satisfactory. Semen analysis showed azoospermia twice, and further detailed evaluation of male partner revealed that primary testicular failure is there. And the wife has now consented for the insemination with donor sperm. So, do we need consent from the male partner to Dr. Jyoti?
Yes, ma'am. Thank you for the opportunity, first of all. And yes, we definitely need the consent from the male partner because of two reasons. One, that they know that a donor IUI is being done. And the second, they also have to endorse that the child born out of this procedure will get all the legal rights of the husband's name. So definitely the consent of the male partner is required.
So basically, any ART procedure, if they are undergoing as a couple, even if we are using any donor babies, donor egg or a donor sperm, they require the consent from both the partners.
Both the pair.
Both the
Yes,
partners
ma'am.
are required for any ART procedure if they are proceeding as a couple.
Yeah, right.
How do we go ahead with the counseling aspects, Dr. Ritu Prabhakar?
Dr. Ritu Prabhakar. Dr. Ritu, are you here?
Anybody else wants to answer any specific things we will counsel in a case of if they want to go for insemination with a donor bank?
Anyone can take.
Couples have so many queries, no?
I think first thing we have to make it clear to them that they have to get the donor sperm from the ART bank. I think that's the first thing they have to understand. And like you said, that yes, issues like these do come, that they want to have a donor of their known somebody related to them so that the legacy can continue. But ma'am, although the word anonymous is not written anywhere, but even the consent form of donor IUI says that the couple will not try to attempt to get to know the identity of the donor. So they can ask for the features that there should be matching of the kind of height, or they can know about the education background or the ethnicity, like a North Indian wanting a North Indian, the complexion, etc. But I don't think we should encourage them about getting a known donor.
No,
And
but
even if they want, it has to be
law says
routed
nothing
through.
about anonymous thing
Anymore. Yeah.
Yes, sir,
anymore.
it doesn't say,
It
but
is
again,
your
they should
own.
consent form.
Rather you should encourage them for a known
Anonymous
donor also if
donor.
they have. No, it's not required necessarily any longer to have an anonymous donor only. So if somebody is more comfortable with the known donor, they are most welcome to get their known donor also, as long as they qualify the legal criteria, the age criteria and all that. If the donor qualifies, so there's no harm. And also you have to see medically, when you are like a sister can't take a brother's, donation, whatever,
That
those kind of things.
Sure.
That kind of thing you need to see, else it's pretty
But
much okay.
yeah, but they should be
Consent,
route through the ART bank only.
Yeah, of course.
Everything has to be routed through.
Yeah.
So basically, we have to explain that this the screening of gamete donors, collection, screening, and storage of semen. This is a duty of the ART bank, the semen bank. So we can just see the eligibility of the donor if they are coming with their own donor. That the male partner should be between the age of 21 years and 55 years of age, and we can they should be screened for such diseases. that
Ma'am, but
I believe
actually, I had a concern, and maybe Thapar, ma'am can clarify that. If you look at the consent form of the donor IUI, there is a line which says that we will not attempt to know the identity of the donor. So
And
does it
read it.
not
No,
contrary in the
read
sense
it.
we get known?
No, if you
No,
have an
read
unknown
it.
donor.
No, read it. In that consent, in the bracket, it's written if applicable. If applicable. If the donor is not known to you, then
Then
you're
it
not
is.
supposed to disclose.
Disclose.
If
Try to get
applicable
known.
only.
Yeah.
Yeah.
and Dr. Jablin, we will not mention anywhere that it is a known donor. In
Yes, ma'am,
our record,
get
we will
it.
not
That the
mention it
bank will take
anywhere
care of
because
it. Yeah.
Yes.
yes,
No,
Yeah,
if
the
because
it is
bank.
coming,
No. Listen, hear me out like this way. Uh, don't be afraid. If it's a known donor, you can record. It has to be routed through a bank for a certain reason. It's
yeah.
not routed through a bank to show that it's, you can't even say or you can't even write. Somebody would have a relation tomorrow, they'll say कि ये तो मुझे ऐसे जानता था,
And it's the
and then
sperm.
you will come
Exactly.
under the
That was
suit.
the concern
Now,
earlier. That's why I think
yeah.
it was anonymous and it
No,
should have been.
now the thing is why you are being asked to route, because the samples are being provided by the
Tested
ART
in
banks.
quarantine.
Hence, the known donor also need to be routed through that, because the sample will come from there who will do the test. The act says that the ART bank will register them, will do the screening and all that. If you bypass that route, directly take the known donor because you know that this is going to be the donor, then you are escaping few essential provisions of the act. That is why we tell them to route it through a bank.
Actually,
Only thing
here I would like to just give one point. Routing through an ART bank, the reason is just to have one authentic responsibility, a responsible organization to vouch for it. So that कल को कोई legal dispute हुआ, तो there is someone that कोई गलत इल्जाम ना
Ma'am,
लगा दे.
adultery वाला issue नहीं होना चाहिए.
absolutely, that is the absolutely, that is the reason why provisions are made, that this entity is supposed to do this certain sort of things under the act, and this is to do certain. The only thing when a known donor, I always suggest that try and create one agreement between the parties, whosoever is a donor. Like a sister is doing a donation for her own sister, so that tomorrow they are not fighting for the child, or there is some sort of issue between them. So that you can, we draft a very nice agreement between the parties, and they can get it signed between themselves to safeguard their interest.
basically we should document that
Yeah, you need to.
donor
You
is
can document. What is the problem?
But Radhika, tell me one thing, that document needs to be attached in the file in the clinic, or that can be, like, most of the time patient says that give that affidavit to us also. Should we pass
Yeah.
on that?
Yeah.
Can we
You
give
can.
that affidavit to them?
Yeah, of course
Have
you can.
affidavit, yes,
Not
patient
a
right.
problem.
We can give.
Yeah, no, not a problem at all. You can give it to them. That's their document. That's their understanding. You can keep a copy rather and give them the original also.
Original copy.
Thank you so much, ma'am, for clarifying that. Thank you.
Yeah.
and this will also documentation will also help that a bank is not find that this donor is not donating for somebody else also, because a sperm or an oocyte donor can only donate to only one committing couple, only once in their lifetime for one couple. So age limits we have covered. So what about the quarantine of women? Let's say if we are use a sample which has been quarantined for not quarantined for 6 months. Can we use or can we not use? Dr. Jyoti?
The quarantine of the sperm should be done for 6 months before they are used, because we have to go for a few medical tests like HIV, HPS, HCV, and VDRL before the semen is used as a donor sperm.
And if they are using a known semen donor and they are not giving state, is there any way we can proceed with this or not?
Because in that case, already the legal agreement is signed. Even if they face in some like health issue in later in life, they have already have a agreement. So we can also only advise them to wait. But if they can't, then
No, they have to qualify those tests. Na? If the test they have to get those tests which are particularly being marked as a duty for.
We are doing the test of the sperm or oocyte donor. These are the only tests which are prescribed in the law. That HIV, hepatitis, and PRL should be done. But if suppose the donor is in a window period, The semen banks which supply the frozen semen, that is, we test it again after a quarantine period for 6 months. And if the couple comes with their own donor and they say that we want to use we route it through the ART bank, and the next month only we want to proceed with the treatment.
No,
So
no,
is there anything
No,
see,
we can
we
do?
can always explain to them quarantine is best, but if they are going with in spite of that, then maybe there is no
yeah.
means we can advise them and take a consent and do that. That's
Because no test can test the window
yeah.
period, so it's better to advise.
Yeah.
We can only advise them only. So
Correct.
Yeah, so best to
But
take a
will the
consent from
bank
your
release the semen which has been stored for less than 6 months with them?
Yeah, typically there
Do
is nothing. Yeah. Typically, there's nothing written under the law
Mm.
that they have to store. The only thing is that they have to get these tests done. As long as they are getting these tests done and they satisfy the criteria, now the point is the window period issue. Now the window period issue can be, ideally for the anonymous donor, this practice should be followed so that tomorrow there is no soup. But for the known donor, as the doctors are saying, all the parties are aware and are known, you can certainly write your medical advice that we advise you to quarantine, so that tomorrow they are rejecting your medical advice is their issue.
yes, we should document that we have
Any
advised
role
them.
of PCR testing of the donor? If we do a PCR testing for one for PCR
You can advise it patient.
in the
But
window
for an
period.
unknown sample, they cannot give before the quarantine
Yeah,
period is over.
Yeah,
And they
unknown sample.
cannot provide that sample. For a known donor,
The
probably
bank
it's their
cannot
own
release.
choice.
It's
They
their
can
own choice.
actually
That's
release.
what. Yeah, that's what we are saying.
We are discussing only the known
So there
donor
is
now.
one more
But
question.
We are not willing to wait for the quarantine period.
there is one more test which the sample is tested for, that is thalassemia profile.
Yeah.
That
That's
is not
mandatory.
mentioned in the in the AR Act, but it is always the sample have
We
already
do
been.
it, but it is not mentioned in
Not
the now. These
it's
only
not
four
mandatory
tests are
also.
mentioned.
Yeah.
But usually they write this report that it is.
We usually do it. They do it.
See, so my advice here is these are the basic tests which the ART bank has to do it. But still, you want to get additional tests done as a doctor, you feel looking at a particular profile of the patient. You please don't compromise on your medical standards. You please advise them those tests to go ahead and get those extra tests done.
Radhika, that we can only advise to the known donor, not to the
To the
anonymous
unknown,
donor
yeah.
that is
We were
coming to
talking
ART.
about
You know,
known
right?
donor.
Absolutely.
Yeah. So there is one question, Rakhi, that is coming in the chat box that couple wanting for a known donor, sperm donor, and they went to the ART, did all formalities and all everything. So can we take the fresh semen sample of that donor in the clinic or the frozen sample that come through ART bank? This is the questions that they want to know.
Frozen sample. Ideally, so we have to take the
Ideally frozen sample
layer
because
sample.
yeah. So ideally it will be a frozen sample, and if couple says ki, we can give the fresh sample in the clinic and we are routed through ART and we did all documentation and everything, then how you counsel this?
Anybody wants to answer?
No, we cannot take in our clinic.
We can refuse it. We can't do it. Dr. Manjunath, can you elaborate on this?
Because
No,
I think
we cannot take in the clinic. We have to route means they have to go and in collect in the ART bank, and the sample should come from through the ART bank only. So we cannot take in the clinic.
because we are not a registered
Correct.
bank,
We
I
are
think
not
that's why.
registered ART bank, so we are
Yeah.
not supposed to take that.
Okay. Thank you. Proceed, Dr.
So
Rakhi.
we have to clarify that the child born to ART then with a known donor, the child would be deemed to be a biological child of the consenting couple, and the child shall be entitled to all the rights and privileges available to a natural child, and the donor shall relinquish the parental rights over the child or children who may be born from his or her gamete. And written informed consent of the specified form has to be taken for the journal consent for the IUI, and the ART bank has they have to also maintain records of use of donor gamete and consent to take consent form for the donor form, and the clinic shall never mix semen from two individuals. And sex selection, it is not prohibited. The clinic shall not offer provide a couple of women with the decision of a predetermined sex, and it is prohibited to anyone to do any act at any stage to determine the sex of the child to be born through the process of ART to separate or yield fraction uh, which are enriched in any of the X or Y variation. Now next case, Dr. Manju.
So next case is 30-year-old female and 31-year male. They are in living relationship, trying to conceive for 2 years, have approached to you for IUI with partner semen. So family is not ready to get married them, but they have approached to you for IUI with the live-in partner. So how you proceed? Dr. Ritu is not here, and how you proceed with?
No, we cannot do any treatment in this case because they're not married.
Yeah.
But I
Ma'am,
think
one trick here is
A known
you
donor
can
of the living.
no
That is some.
no you can
come as
register
a
as a
single female.
single mother and do it.
Yeah, she will be
Single
registered as a
mom.
single mother, get
Yeah.
a known donor of the living partner.
Yeah.
That can be done, but
Yeah.
But what
direct
are the
case
legal
Yes.
So
it cannot
suppose
be
they
done.
register her as a single woman, and now how you counsel this woman because they are in living relationship, they want their own child.
So
But
let me
when
put
he,
it, yeah.
See,
Let me put it in a
I
legal
think
way.
Thakral is the best. Legally, live-in relationships are recognized, but medically, there is no comment on that.
No,
Yeah.
So,
the live-in
Let
husband
me
will not have rights over the child. It will
Yeah,
be like
the
he
male.
will have to adopt the child. Yeah.
No. So let me just put it in a legal way. The trick that Dr. Manju is saying. See, basically, we have to put that trick in a legal way, right?
yeah,
Because at the end of the day, it has to have a legal sanctity around it. See, live-in partner, when a as of now, the ART Act has recognized only leave apart what the other acts or what the other norms of the society is. So the basis of your entire act or your work legality around your workspaces for a heterosexual married couple. Okay. So now this does not qualify that. You may have a right under a Domestic Violence Act, but you do not have a right under the ART Act, which has as of now given only marriage as a status to have children. So this lady either have the option because her live-in relationship is no longer recognized, so she's single. She's not married. She's single. So there is no, if you see, there is no trick. She need to accept the fact that she's single.
Yeah.
And she's
yeah,
under the presumption that she's in a live-in relationship that has altered her status. No, that hasn't altered her status. She is a single woman. All that we can help her with, that if she is very comfortable with the man and she wants the man to be the genetic contributor, then we can take that man's sperm as a donor sperm. Okay, but the man will not have a right over the child as per law. Tomorrow she can make that man a guardian or allow by will to interfere in her life. And tomorrow, once they marry, after supposedly, I'm now witnessing few cases where they're steady in their relationship, but for some reason they are not ready to marry at the point. They might marry in the future. So if they will marry in the future, then we will help them or we can guide them legally how to get the child rights, but this is how they can contribute the genetic material, helping as a live-in partner or a friend only, but they cannot get the rights of the child.
yes.
So
So
very right. We see such cases routinely now. We are seeing whether the family is not approving or there are some religious issue that this at this time period they will get married. So we see many couples and then we explain to them that like in a known donor, the partner semen must be routed to the ART bank and the male partner will have no rights and responsibilities towards the resulting child.
Radhika, as a legal advisor, do you advise them that they go through the ART bank and become a donor, and later on he
Of
can
course,
adopt
I do
that
that.
child,
Of course,
and
I
later
do
on he
that.
can adopt?
You,
Yeah.
of course, see why people are opting for live-in relationship. They don't want to tie around with all that comes along with marriage. It's a free relationship. You can walk out and walk in. So you're not understanding. You're trying and testing. Some people are trying and testing to see whether that's a compatible partner for whatever reasons they have in their head. So it's a completely नॉन बाइंडिंग थिंग कि कल को लिव इन पार्टनर 10 साल का अगले सुबह दिन बना ले अपना माइंड कि भैया ओके फाइन थैंक यू आई एम गोइंग टाटा बाय बाय, यू कांट गो इन द कोर्ट एंड क्लेम भी ये मेरे बच्चों का बाप है, इसको बोलो मेंटेनेंस दे, ये मेरे इसके ऊपर इनहेरिटेंस आएगी, इसके ऊपर नहीं आएगी. सो सॉरी, आई मीन यू हैव नो स्टेटस लीगली to claim the child, to become a father, and the ART laws can't help you with that. Be a donor if you want to help, and even if you're looking forward for a future with her, either marry today or tomorrow, but at the moment you can only be a donor.
Okay. One question, Dr. Thapar.
Yeah.
This thing, leave the ART procedure. If they conceive naturally, so then the man has a right on the child?
No, then also man does not have it. It's an illegitimate child. The illegitimate child belongs to the mother always.
Okay.
The legitimate child, so थोड़ा सा हमारा पेट्रियार्कल सोसाइटी है, वियर्ड है. So आप शादी कराओगे तभी the fruit is possessed by the man, right? So तभी वो legitimate होता है. Illegitimate child always belong to the mother.
Oh, okay.
Dr. Radhika, what is the doctor's liability if the couple dies and forges their documents? The age, the marital status, we see many couples these days with these things also. How can
Of
we
course,
ensure what is our liability?
हाँ, सो देखो, एक तो होता है फॉर्जरी कपल ने एक्चुअली रियली किया है, एक कपल ने कनाइवेंस विद द क्लिनिक किया है. सो उसमें फर्क होता है, यू नो. इफ द प्रूफ लेटर कम्स अप समहाउ, कई बार डॉक्टर्स फील दैट यू नो दे हैव वेल टेकन केयर ऑफ एवरीथिंग, लेकिन किसी पुरानी फाइल या किसी पुराने रिकॉर्ड पे चीज आ जाती है, then the doctor is going to be in trouble. But always self-attest the documents that you are taking from the patient. Let them self-attest it with a date. Suppose you are taking it today. Today is 12th Feb. So you take it, you know, so and so sign 12th Feb. ऐसे करके वो आप डॉक्यूमेंट उससे लीजिए. And if you are very careful, you can even get an affidavit or any consent made in a regular structure that all documents which are provided by you are true and genuine, and you have not faked or lied up anything to the clinic. एक आप स्टैंडर्ड डॉक्यूमेंट हर पेशेंट से साइन कराइए. देयर इज नो लायबिलिटी ऑफ द डॉक्टर एज लॉन्ग एज कल को पेशेंट प्रूव करता है ये देखो डॉक्टर साहब के साथ एक टेक्स्ट है, एक व्हाट्सएप है, एक ईमेल भेजा हुआ है, एंड उन्होंने ही बोला फेकअप कर लो, उन्होंने ही बोला चेंज कर लो. सो देन यू आर इन अ सूप, देन दिस गोना बी नॉट ऑफ सम हेल्प.
Yeah, so that means we cannot do.
Yeah.
Stop sharing.
So
Dr. Ravi, your screen is.
So whatever is genuine, genuinely आ रहा है, ऐसा कर रहा है. आजकल ना फेकअप रेयरली होगा, बिकॉज अब लोगों के आधार चेंज करने, एटलीस्ट द एजुकेटेड स्ट्रेटा सब कुछ लिंक हो चुका है, तो कोई इतनी जल्दी फेकअप करेगा नहीं.
So we have to take an extra consent that all documents are fact from them. What do you say?
You can take. You can take an extra document that all are the everything which is provided by them is true and genuine. अभी तो क्या होता है, ये तो आप मुझे एक सिर्फ सिंपल बात बता रहे हो, किसी ने एज फेकअप कर ली, फोटोज भी नहीं दिखती, कोई किसी को ले आए बोले यही मेरा हस्बैंड है, एंड आधार भी डिफरेंट है, कुछ भी डिफरेंट है, तो वो थोड़ी सी चीजें और स्केरी हो जाती हैं. बट यू कैन यू नो हैव दैट एज एडिशनल हेल्प. राइडर्स में 2 राइडर्स लिख के ग्रुप पे भेज दूंगी, वो अपने सारे प्रिंट करवा लो अपने लेटर हेड्स के नीचे.
Please, that will be help. इस ग्रुप में डाल देना please, Radhika.
हाँ, I'll put it across.
You are a great help to us.
Yeah, of course, any day. The entire doctor fraternity is a family to me.
Yeah, that will be good.
Very essential. I want to pass this message because we see many couples. When we see that we need a proof of marriage or a marriage certificate, or we need them to make an affidavit that they are married, then they disclose the reality that ultimately they are in a relationship, or they are bearing this child for their sister or for their brother, and the person who has come as the husband is not actually the husband, he's the brother-in-law. So I have dealt in many cases like this. So it's very essential that we have to take an affidavit for some proof that the commissioning couple is either married or it's a single woman who is undergoing the treatment to ensure our safety in the future. Manju, the next page, please.
Okay, 36-year-old female currently separated in process of divorce approaches to you for IUI with donor sperm. Now, how you counsel? And husband consent needed or not in this case?
So we surely cannot do it.
She is not divorced. She is in a process of divorce.
Process of divorce, yeah.
Yeah.
So,
Now tell how to counsel, and do you take husband's consent over there? Do you proceed with IUI with donor sperm or not?
we surely cannot because she's in the process of separation. So probably I would counsel in a way that get this thing sorted first and then do any ART procedure because she's not eligible since she's not legally separated. I'll tell her to come back with the proper divorce papers and then probably we can proceed with the treatment.
So how you counsel her? She said she is going to tell you I'm 36-year-old. I don't know when we are going to the divorce paper and all that. So till that time, what you do and
No,
what
the
you
counseling becomes very easy where there is a law, we cannot go beyond this. It gets very easy when we tell them that, this is our boundary, and if it is not allowed, it is not allowed, and we cannot just separately, put you in a bracket that we can do it for you and not for anybody else. Just wait for the proper divorce to just get the proper divorce papers and we can,
Okay, Dr. Jyoti.
thankfully, she clearly told that she is going through a separation process. She could have just come and said that she is single, so that way probably she's quite.
So we counseled her, Rubeena. We counseled her and you can go for oocyte freezing, but
Yes.
not for IUI, donor IUI.
Yes.
So can you
No,
put
no,
the
no.
oocyte freezing without husband's consent?
So
No, you can't freeze without husband consent.
No, you can.
No,
we can
oocyte we
freeze.
can.
Oocytes we can freeze.
Oocyte.
Yeah,
No.
oocyte you can freeze.
Any fertility related procedure, husband consent is a must.
No.
No,
No, no,
not
no.
freezing is okay. Freezing is okay without husband consent.
Yes.
Is it? Is it?
Yes.
Yeah.
Absolutely.
See,
Have you lost many patients?
no, no. No. I was under the impression that for tubectomy also husband consent is required. Any fertility.
Something.
No. That's the autonomy over your body. Na? Your husband can also go and freeze his sperm somewhere. Na? Wife can also do it. So that's not a problem, even if you have a divorce or any sort of issue. The only thing is you can't procreate. You can't have a baby out of it.
Yes.
Right?
Okay.
Without the consent. Yeah.
Oh, I didn't know this. Thank you. Okay.
Radhika, I have a question. What is the minimum age of egg freezing? Like, do we need just for example for ART?
There is no minimum age or anything.
No minimum age. There is no
The
minimum
same criteria
Same
21.
applies.
21.
Even
Yeah.
No,
even
for
earlier also
example,
for fertility preservation, you can do it earlier also with
Earlier
assent
also.
and
There
consent.
should be an
earlier.
indication. You can do earlier also.
Indication. Only in indicated.
Only in
like you-
special cases like cancer.
Special,
But
yeah.
the
Cancer patient.
Okay.
Only in special cases.
Yeah.
Otherwise, you can't touch the
Social
body
egg
of a very
freezing
young.
you can't do. Social egg freezing you
Yeah.
can't do.
Can't
But if
do,
there is a
yeah.
special indication, you can go ahead with the.
But
Yes.
do we need to keep any document for that, or we just need to take any permission, or just affidavit or something we have to take, or?
Of course, you just need to take a permission.
No permission is required. You directly go ahead with the oocyte scientific paper, oocyte retrieval consent and all counseling, consultation and egg retrieval. All you can freeze and frozen the consent for cryopreservation. You need to sign.
See, so for few of the patients, some of the doctors get one documentation done in front of me because you are freezing your oocyte, so you should be knowing what all you can do at what stage of life. So better we explain, counsel them. So what has happened, one of the Gangaram case which became a very big highlight, I think a couple son died, this cancer patient, semen freezing हो गया, कुछ भी नहीं है, ना wife है ना कुछ है, and बाद में वो sample का क्या करें, surrogate you can't use. So to navigate out of all those difficult situations that you need to have a lawyer also. You can advise the patient in critical junctures. Okay, you are preserving this today, tomorrow when you marry, then you can use this. Before marriage, if this is the situation, you can use this. Up till for 50 years, you have to get the IVF done. Otherwise, you can't do it in India. There are age barriers also. So we do this sort of counseling for a lot of our doctors.
And one thing more, if the female is less than 18 years, parent consent will be taken.
Yes, mine consent.
Parental assent. Patients assent, patients
Assent of the
assent,
child,
and
the
parents
consent.
consent.
Okay.
बच्चे को भी थोड़ा पता होता है ना, 12 years के बाद का बच्चा थोड़ा अवेयर होता है, उसको समझ आती है. So around
Okay.
16 years would understand, तो उसको थोड़ा समझा के काउंसलिंग करके and patients consent.
Okay. Thank you.
Patient and legal guardian consent.
Yeah.
Okay.
Raki, you do the
Routine
slide.
cases can be stored for 10 years, not more than 10 years.
Yeah.
These cases, unless it's the case of fertility preservation. We have to explain that easy.
And in the consent, there are some conditions and indication where we can discharge.
Preservation can be more than 10 also, ma'am. Exceptional.
Yeah, exceptional cases, you can have more than that also. And if I am not missing on, there is a provision that if you wish to extend, you can have certain permissions from the local authorities also.
Can I ask a very important question, Dr. Manju? In the middle of the panel.
Thank you, ma'am.
Suppose a patient comes to us and says that my sister's sister is in Australia and she wants to give me egg donation and she's in the right age as per your law. So can we take egg donation from sisters who are Australian citizens or citizens from other countries and not holding OCI cards?
Not holding OCI. Radhika?
Yes, you can take. You can take, there is no problem. Foreigners can also come and make donation in India. So that's not an issue at all.
So they have to come through the medical visa. Do they have to take medical visa?
Best is if they, best is that if they can take the medical visa. However, of lately the government is promoting medical tourism also, and there has been one of the orders where it says that any procedure which is less than a stipulated period of this much time can be done on the tourist visa also, right? But if she can do, because if you file in that, there is an ART procedure which is to happen, embassy easily gives the medical visa also. I haven't heard any problem which is coming the way.
So Australian as well as Indian embassy, she has to go to both the embassies.
No, she has to go to Indian embassy. For visa, the country you have to apply where you have to go. So you have to apply to Indian government to give you the visa. You cannot write it. I mean, there's no need to write specifically you're going for donation. They may understand or not. They can write. It's also an ART procedure. It can write that I'm going for an ART procedure in India.
Okay. One more very important point. Can I ask Dr. Manju, because it's our everyday practice? Can I ask?
Yeah, Dr.
Thank you.
Go ahead. Please go ahead.
America, one of our patients who was a doctor, she insisted that the known donor that they want to take is they don't want to freeze their semen because it was a young donor. So they just want to take the fresh semen sample after doing all the tests on the day of IVF. Is it acceptable?
No.
No, like routed through the bank. No, routed through the bank. If it is routed through the bank.
Ma'am, through the bank.
The bank won't give, ma'am.
मैम ऐसा है, देखिए एक्ट सेज कि द एंटायर कलेक्शन हैज टू हैपन विद द ART bank. So in fact they wanted the donor retrieval should also be done with the ART bank. That's the basic spirit of the act. But incidentally, India does not have that sort of demarcation or infrastructure available with the ART banks. So with a special, you can say, approval or modification, the government has understood that oocyte retrieval can only be done by an ART clinic. Hence, it is allowed. But because semen processing, semen collection, everything can be done by the ART bank, which does not require a major infrastructure. So hence that has to be done there and then quickly transported. How fast they can do it, I really don't know. How fresh, what it means if a couple of hours before it is given, how it could be done, all those tests to be done. So that is where it is.
So if the ART bank is just 15 minutes, if it is 15 minutes away from the ART center.
Sometime what happened, the clinic and ART bank in the same premises, yes, the problem is there. Then tell me whether they use the fresh sample or not. Whether the bank provides fresh sample or not.
Yeah, of course, why not? Why not? Yeah, they can.
Dr. Prabhjot, they can give. If they are very nearby in the same premises, you can take the fresh sample also, but bank will take the fresh sample and give it to you.
And that is why gradually what Delhi government I'm hearing, and maybe over a period of time, all of you would be asked to open your own banks. All of you would be asked to open your own banks.
So can we discuss next case?
Yeah.
One of our gynecologist friend have a level 1 ART registered center. She has a couple of planned IUI with donor sperm, and there is no local semen bank, and she has to procure the semen sample from some other city or from some distance. Can she arrange the sample and store it in her center, Dr. Lakshmi?
She can.
So yes, she can, because it should be for that particular couple only, for which she has asked it for. She cannot use that sample in any other couple. So that is it. But I am not sure ki for how much time she can store the sample, because there is no mention of this thing in the act.
Yes.
As long as there is an ongoing treatment, the sample can be stored, and it has to be again routed through an ART bank. Remember that. Yes. Whatever, even if it's in the same premises, yes, the documentation should be complete. The identity, the ID number of the donor should be given to the ID number of the intending couple, and it should match in all documents.
Yes,
Right.
ma'am.
So, but if in case we if the treatment has been postponed for like 3-4 months or maybe 6 months, then can she store the sample till that time?
Yes, she is undergoing the IUI.
Yes.
And well, that IUI is positive.
There's nothing mentioned in the act regarding this.
Right. So there is no mention of the time period for how long she can. But then, of course, if there's no mention, then we assume that she can store till the couple is going in for the treatment.
Yes. So what are all documentation and consent in this case?
So documentation is very important, because we need the form 8 has to be signed by the couple, which is like for the donor IUI form, which is given in the ART, and the documentation by the, I'm not sure whether form 15 is required if she is storing the sample for a long time, because form 15 is for the banks.
Because she is not registered with the bank, she can't store so long. So form 15 is not required, I think. Only the documents
for the bank.
She should have the requisition like that for this, which patient she had sent the request for, and what is the
and the detail about the
document
donor and HIV and all detail about the donor, that and the sample. She can keep all these records, only this. The ID of the donor sample is very important. All those papers should be in the file.
Yeah. So form 15 is not required to be there.
required. No.
Yes. Yes. Okay.
So the next case is a 35-year-old female and 54-year-old male. They have been married for 10 years and they plan for IVF. So what is the counseling which is needed regarding their age? The age limit is for the start of treatment, the day of ovule, or the day of embryo transfer. Dr. Jacqueline?
Yeah, ma'am, they have to understand that the male partner has a very small window for the final procedure. And basically, the age limit of 55 is for the day of the embryo transfer. So they have to understand that even if they start off with all the process, if the man crosses that 55 years cutoff, then they will not be able to go ahead with the embryo transfer finally.
However, they can approach Radhika and take a special permission. Right, Radhika? Hello.
So sorry, I missed. Yeah.
I
So
said
sorry.
the patient can approach you and take a special permission in case that window is being crossed between the pickup and the transfer.
Or
yes,
suppose
but
she miscarried the first attempt and has embryo. Now, so we have embryo. So can we transfer or can we?
Sorry, is it a question posed to me? I can't hear.
Yeah, it's a question for you.
Yeah, so this is a very typical situation which has luckily so far been handled very positively by the judiciary. Supposingly, there was a borderline case where the couple had a age, or for any matter, they had decent years in their hand over a period of time. They were doing the treatment, miscarriage happened, they have now, they for some reason they cross the age barrier, either the wife or the husband, they have the frozen embryos. So there are these judgments, which were very so far helpful, has said the ones who are already in the line of the treatment, did not start the treatment when they attained 55, but you can show the journey that they were previously in the treatment, and this happened, and that this then the courts are allowing. But at the moment these powers are enjoyed by the courts, they have not deliberated or given it, passed it on to the officer level. So far what is going on is, if you have a critical case, the officers are saying go and take a court order, we will allow it. So we have to go to the court, we have a judgment favoring it, so we are hopeful that such similar cases will get relief from the court.
So we have to understand that we cannot do it on our own, and we have to have a judgment allowing this, and then we can transfer those frozen embryos.
Yeah.
And we have to explain all this to the in our company.
Yes.
So we have another case, a 40-year female and a 45-year-old male. They have been married for 2 years, and wife has custody of one child from her previous marriage, and she underwent a obstetric hysterectomy at the time of her previous childbirth, and now they have approached you for surrogacy. So how to proceed? How will you counsel them whether they are eligible or not for this? Whoever wants to take this case, answers this.
Okay. Who will answer it? Dr. Jyoti?
I think they are not eligible because they already have one child.
But that is from previous marriage. From this marriage, they have no child. So,
but we have to see whether, okay.
Radhika, this couple has one child from the previous marriage. Now hysterectomy is done, like uterus is removed. And do they proceed with the further IVF with surrogacy?
I am very clear on this. The case goes in their favor, right? They don't have the act defines the present marriage, right? The act defines the couple, intending couple. The couple who are approaching don't have a child of their own. If they have a child they are not taking care, their motherhood, the lady's motherhood is suffering because not parenting the child. They have no child actually. पहला बच्चा था वो उस बीवी के पास चला गया and all that, they want another child.
But
so in
that child is staying with the couple.
If that child is staying with the couple, तो अब उसमें दो चीजें आ जाती हैं. If they have formally adopted the child, then certainly they can't go ahead. ठीक है, उसने self second marriage के बाद में self adoption, what do we call that, the step parent adoption कर ली है, then you can't go ahead for this thing. अगर उसने step parent नहीं की है, so in that particular situation, court will ask you and can take their own decision depending on how they are convinced about that.
And if couple legally adopted a child and with some other problem like recurrent implantation failure, genital TB and plastered uterus, no menstruation, and are not able to conceive with IVF, and do they are eligible for surrogacy?
No, they are not. They are not. And only if that adopted child has a chronic disease, then only they can go ahead. Otherwise, not.
This has been covered by
the agenda of the surrogacy as of now, the government wants that, at the end of the day, the juridical point around is that, to give every family at least one child, right, if they don't have. Beyond that, the government does not want to burden other women to procreate for other couple who wants to add on a sibling or for any reason. So that's the point. At least your craving to become a parent, at least that is what is being looked at upon when the government passed this act.
So Radhika, I had one query. What this day of certification is, they get the all the permissions on the day
Yes, this is
whether
how
they
I.
get the eligibility
Yeah,
certificate.
yeah. So what happened? I'm pursuing one more case, and I'm very sure that this is how it has to be interpreted. It's on the day of certification when you get the approvals. Now, supposingly the couple got approvals a day before they turned 55 or 50. That does not restrict them to go ahead and get the ET done in the surrogate, because this couple is not going to be the carrier. Okay. यहाँ लेडी 50 की हो गई, she's not going to the carrier. It's just that from on the day of certifying, they were within this prescribed limit. And if you read, the surrogate should not exceed 35 at the date of implantation, right?
On the implant.
On the day of implantation. बस carrier की age ज़्यादा important है. इनकी age from the longevity perspective है, so government ने उनको certification. उसके बाद में कोई बात नहीं, 56 की age में भी जाकर अगर transfers हो रहे हैं, so which is okay. I mean, that does not deter or bar them.
The thing is, if they are using this full certification process, is currently taking kind of time. So if it is
अगर
taking
सर्टिफिकेशन में इन्होंने 55 while we are making them through the process and they tick that 55 years का bracket, then they can't go ahead. Certification ही नहीं मिलेगा. All the approvals, essentiality, they should get it before 30, मतलब before this they hit 55 or 50.
And that is why I wanted to clarify.
Sorry, your voice is breaking.
I wanted to clarify that essentiality or all the permissions.
All the permission. Technically, the construct of the act is that you should have all the permissions. Supposing you take 2 permissions. In some authorities, essentiality is given before, court order is given later. For any reason, judge does not give you the court order, and then you will again stuck. Then the birth certificate will not come properly. So I don't want in any given scenario any problem posing to the couple or to the child. Better get all your certifications done, and that's what the spirit of the law also.
So we have to counsel the couples that they should start all this process in time, because they land up in the IVF process at the last.
Believe you me, I have seen a change over a 3-year period also. I still remember they were so used to कि इंडिया में 1 मिनट में इतना काम हो जाता है, 1 मिनट में ऐसे हो जाता है. And a lot of other lawyers also started giving them that kind of, and I was very fixed कि देखो ये time रहेगा. I did not budge from that, right? And I used to at times feel also कि पता नहीं लोग इनको क्यों बोले जा रहे हैं, बहुत जल्दी करा देंगे and all that. It will take time. 6 महीने, 4 महीने, 3 महीने लगेंगे paperwork में. And I stood to my guns and I was like very firm. I can't, misguide or misinform a patient or, inform otherwise to, pacify them. Sometimes आप ऐसे अच्छे words बोलते हो ताकि उनकी anxiety कम हो. But the point is, अब लोगों में change आ रहा है, patients में change आ रहा है, जो जगह जगह घूम आए हैं, देख आए हैं, struggle के through हो रहे हैं. Lot of my patients now know कि इसमें थोड़ा time लगेगा. So it all depends how we counsel patients. All depend as a fraternity all across, सब एक ही जैसा कहे, कोई एक डॉक्टर कंपटीशन के चलते मिसगाइड ना करे. So all these things we need to be very careful about.
This is the last case and we'll run.
A gynecologist has registered for her clinic as a level 1, but she has no ultrasound in her clinic. And she planned to do an folliculometry from radiologist. She is used to do folliculometry from a radiologist friend that outside her center. Now radiologist said that patient is ready for IUI, ovulation and all. He confirmed. And can she plan IUI at her center? And does she need to register herself with Pcpndt? She is registered as a clinic 1 ART center, level 1.
Yeah, he needs to.
With Pcpndt, because but she don't have any ultrasound.
No, it doesn't matter. Ultrasound is one of the mechanisms. Yeah, you are handling the gametes outside. Abhi thoda sa, I think the authorities are a bit more also clear about the law. Earlier it was more centered कि USG है तो मतलब PCPNDT चाहिए. Now they are saying no, wherever there is this sort of any activity going on, handling of the gametes outside the body or whatever, धीरे धीरे ART banks को भी ये PCPNDT register करेंगे. That's their idea.
But presently, do the authority can give the registration without ultrasound? And if they don't have ultrasound, do she need an PCPndt to register? And in which heading she registered? Genetic counseling, genetic center, genetic counseling lab, or an imaging center? Imaging
Imaging
center,
center,
definitely she
imaging
don't.
center नहीं आएगा, genetic lab नहीं आएगा,
Genetic counseling center.
काउंसलिंग आएगा, GCC आएगा, कुछ तो
Genetic
उसको लेना पड़ेगा, GCC.
So
अभी
under that
GCC तो
heading,
हाँ, अभी रिसेंटली दिल्ली में तो GCC कह रहे हैं आपको सबको लेना पड़ेगा, जिसका
GCC support.
सबको लेना.
GCC and GC is for everyone whosoever doing the gynae practice or obs
Yeah,
practice, because we need to find patient for a genetic issue in obs also for NIPT and
yeah,
for serious counseling is there, and GCL the lab that is doing for the diagnostic
yeah,
procedure.
yeah.
And I believe there is some disparity at the state level also. Dr. Nirmal can answer better if she's here. That I have heard in some states they are not giving a level 1 without an ultrasound. So if someone can clarify this, that
Can you repeat the question, Rakhi? I missed the question.
Can gynae get a level 1 ERT certification without an ultrasound, or is it mandatory? Because it is not mentioned.
Yeah, in the law, it is not mentioned that you have to have an ultrasound machine. So level 1 ka jo criteria hai, that is just a gynecologist, centrifuge, microscope, and
Laminar.
refrigerator. Not even laminar for IUI.
Refrigerator.
But
Yes.
I had heard that in some states, but Punjab, somebody was mentioning that without an ultrasound, the authorities are refusing to give a level 1.
Actually, there is still an overlap between PCPNDT and ART authority. And in fact, the PCPNDT staff is only looking after the ART department in some districts, most of the districts. So that is why there is this confusion. But I think we should clarify, being members, and make everyone understand that an ultrasound is not required. Follicular monitoring can be done anywhere.
Yes.
So
Yeah.
for a level 1 registration, you don't require an ultrasound.
Should not be mandatory. Should not be mandatory.
It should not be mandatory, but still, because you are genetic counseling, you should be registered under PCP.
Yes, PCPNDT also. We are filling forms, IUI and IVF forms for PCPNDT also, even now.
Yeah.
Yes,
Yeah.
ma'am. We are also filling in Gurgaon.
I've just mentioned what are the form numbers which are mandatory under the ERT procedures, form number and the different forms for that. But they have not given the list of all the forms which are required under ART treatment. So there might be additional forms which you have to make for your own procedures, like for embryo transfer, for a surgical sperm retrieval, so lapro, even IVF or extended donor sperm. So these there is no format for these forms in the Act and the rules. So these additional forms you have to make your own and get them signed with the patient. And for the ART procedures also, we are doing filling this Pcpndt form for the OPUs, the embryo transfers, IUI. In some states, we are filling forms for the semen analysis and the follicular monitoring also. So this is the in one RTI, we gave the list of the forms government answers, which forms to be filled for which procedures. So we come to the end of the this session, and there is a question in the chat box that can we do an insect retrieval after putting all the papers, or should we wait for the final approval of surrogacy? So can we proceed with IVF, or should we wait for the
For all the
final
approvals,
to come?
yeah, for all the approvals, we need to wait for all the approvals, yeah, which are there. This is technically what is, because what if you're gonna do surrogacy and you don't get the approvals, so what these embryos will be of no use. But sometimes what happens is that the AMH levels are falling or on a very lower side, so then we do try and put up the case before the medical board and seek their permission for fertility preservation, so that in some cases then the patient says that if I don't get the approvals then I might go for IVF also. So these kind of situations we can try and take a nod of the medical board and go ahead considering the situation in hand.
There is another very good situation. Yeah, go ahead, Rakhi.
I have one more thing.
Did you go ahead? Huh?
How easy it is to get a retrospective, like suppose you did an IVF for a cell transfer, and later on you came to know that the patient, for whatever reason, now they require a surrogacy. Maybe the implantation failure, any health issues, or their multiple portions or miscarriages are there. They have embryos are already formed. Initially, they were formed for the purpose of IVF of the couple only, and
Perfect,
now they want
perfect.
to
That
go
can
for
be
a
used for
surrogacy.
surrogacy. Yeah, yeah, perfect. Can be used. Yeah,
They
yeah, of
can be
course.
used. No?
The medical history will show in itself, no?
Okay, so any other question from
Can I ask a question, Dr. Manju?
yes, ma'am, please go ahead.
I came to know this time when I went to the conference, ISAR conference, that no one fills any form in Gujarat for doing IVF. You know, no forms are filled, no F form or any forms are filled for doing IVF. And I would like to ask Radhika ji, is our IVF any
No,
diagnostic procedure?
no.
Is it a diagnostic procedure?
Oh, that's a
So
treatment.
for the Form F and all.
Yeah, is it because wherever we want to send a genetic material for any diagnostic test, because in 2014 a notification came whereby there was a typing error whereby they said that when you take a genetic material or for sending to genetic laboratory rather than for sending to genetic laboratory. I think the person who typed, there was some error. So in Gujarat, someone was telling me that no one fills any form for doing IVF. Though we are filling, like I am filling Form E, Form D, and Form G.
Yeah. So Dr. Prabhjot, ये हर स्टेट की अपनी इंटरप्रिटेशन हो गई ना
All
गुजरात
about
if
local
you are
authorities. Yeah.
local
No,
authority.
But what about the Central Act? If someone fights a case in the court of law, like I have no problem because I am a genetic counseling center, genetic clinic, and genetic laboratory. So
Yeah.
I know very clearly that because I'm a genetic laboratory also, I will be filling Form E, Form D, and Form G. Even if
Yeah.
I have doubts whether to fill, whether not to fill, I'm not convinced, but I'm just filling these forms. I just don't want to fill a F form unnecessarily because of the very clauses, attached with the Form F. So I was just wondering that if Gujarat is not filling any form, that means the Central Act perhaps do not require us to fill Form F for IVF. Even if
Yeah.
we are genetic counselor, because we are not sending any material for testing. We are not
That
sending any
yeah.
genetic material.
So that's a very good point. Point.
Dr. Prabhjot, we are not sending anything
Yeah.
outside to check it, but we are taking it in our lab.
Yeah.
We are handling it. That's why some are explaining it, because you are taking in your lab, you are handling it. We don't know you are checking or not checking. And if you are taking inside your lab, then you have to take the consent. So
So
these are the explanation from the different authorities,
different authorities. Yeah.
authorities.
So, Dr. Prabhjot, you have a good point. Let me put it in this way. Why the disparity? Why the disparity? So, if there is a disparity, that means the Central Act does not give a straight away instruction. So, the disparity, leads to not the standardization or uniformity of process or documentation in the entire India. It can switch, the procedures which can't happen in Haryana can go and happen in Gujarat because of, not these processes. It can be taken up with the central government, leave apart with the court. You can make on this formulation, let me go through it, and we can certainly make it to the Central Health Ministry for them to lay out a clearer guidelines and not leaving it into the hands of the state authorities.
Radhika,
Yes, Radhika.
but
Actually,
don't
Form F.
yeah. They
Hello.
don't tell us to make the form F and all.
देखो
We
अगर आप
just
ये बोलोगे
make
फॉर्म
it
एफ
BF only.
वगैरह, फॉर्म एफ के लिए तो गवर्नमेंट बहुत पर्टिकुलर है. फॉर्म एफ मुझे अभी टू बी वेरी फ्रैंक, आई एम नॉट रियली गेटिंग व्हाट इज, आई नीड टू पुट माय हेड टू इट. जहां जहां आपको डिस्क्रिमिनेशन या डिस्पैरिटी लगती है, आप उसको एक फ्लो चार्ट में बनाकर ये फॉर्म यहाँ भरा जा रहा है, दीज आर द प्रोसीजर्स फॉर विच वी फिल, एंड इन दिस स्टेट देयर इज नॉट डन, उसको फिर हम प्रोजेक्ट कर सकते हैं. देन आई विल गेट द क्लियरर आइडिया.
No,
बट अगर
Radhika,
आपने
ART bill, ART law, they doesn't tell us to form fill. Only PCPndt for the
PCPndt, I'm saying. Yeah, PCPndt. Sorry for.
And in PCPndt, suppose a lady comes to you and she collapsed. She is not able to give you the consent. And in PF form, that is the mandatory woman signature to be taken to do an ultrasound. If she is not able to give consent, then to whom we, matlab, how we approach this case, how we do ultrasound.
देखो, medical emergencies are always an exception to any standard rule. If somebody has collapsed, just make a prescription at the moment patient reached in this pretty much condition. And because of this reason, हमें उसका ultrasound, because हम आपको diagnose करना है, why is she fainted, you know? So आप कीजिए, there's no problem. वो center radar पे आता है जहाँ एक
Already, suppose she is pregnant and she collapsed, and we want to know whether the baby is okay, fetus is okay, no fetal heart is okay or not, and
मेडिकल
she's not able to
इमरजेंसी
give
है ना,
consent. So
देखो
then
उसको करो, आप बेस्ट जो आपका मेडिकल स्टैंडर्ड है
in law
उसमें
there is no option for this.
Yes, you have to create a special emergency case. You have to create that. There are situation scenarios जहाँ पर कोर्ट ने बोला है, अभी आप मूवीज भी बन गई उसके ऊपर. परमानंद कटारा का केस है, एक बहुत फेमस केस है. वो पेशेंट लेके जा रहे हैं स्ट्रेचर पे, रुकिए रुकिए रुकिए, पहले ये फॉर्म साइन कीजिए, पहले ये फॉर्म साइन कीजिए, ये फॉर्म साइन कीजिए. So there's a stop all this nonsense. Take the patient emergently to there. You bypass all the rules. Emergency does not qualify किसी भी तरह का कोई भी उसको करना. आप इमरजेंसी नोट कीजिए, टाइमिंग नोट कीजिए, बीपी पल्स उसका इमीडिएटली नोट कराइए. अगर खुदा ना खास्ता आपने उस टाइमली उसको एड नहीं दिया और बच्चा मर गया, उल्टा केस पड़ जाएगा आपके ऊपर. एट दैट टाइम नथिंग मैटर्स अ लॉट. और उसके बाद you have a very strong legal case.
We have to prove ourselves ना, not in front of the authority, in the court में prove करना पड़ेगा ना हमें तो.
वो तो सारा आप करेंगे ना. मैंने आपको आप मुझे बताओ फर्स्ट एड क्या दोगे पेशेंट को? पूरी फर्स्ट एड देनी है उसको. आया कितने बजे
फर्स्ट एड तो वही है कि पहले से थोड़ा सा वो किया जाएगा, मतलब रिससिटेट टाइप होगा, फर्स्ट एड तो दी जाएगी. रिससिटेशन के बाद भी अगर पेशेंट आईसीयू चला जाता है, रिससिटेशन के बाद भी नॉट इन अ फुल कॉन्शियस स्टेट एंड शी इज नॉट एबल टू गिव कंसेंट.
डॉक्टर मंजू ऐसे नहीं एक्शंस कोई भी नहीं लेता. ऐसे एक्शंस वन ऑफ द इमरजेंसी केसेस में कि बहुत ही आर्बिट्रेरी ऑफिसर है जिसको किसी के साथ कोई प्रॉब्लम है, पर्सनल वेंडेटा है, कुछ है, देन ओनली दे में गो दिस. द पर्सनल इमरजेंसी केसेस में मतलब वकील ना खड़े हो जाएंगे आप लोगों
No,
के.
I'm asking this because one of my colleague told me that a decoy patient came to the clinic and she told that ectopic pregnancy, and she collapsed in the center and doctor did an ultrasound without any consent and the authority caught the doctor.
नो तो एक्टोपिक पेशेंट है, वो कोलैप्स कर गई, आपने रिससिटेट किया नहीं किया ना, उसको रिससिटेट किया, सारा प्रोसेस करते वो जैसा था रिससिटेट करने का प्रोसेस करते इमरजेंसी में, फिर से अल्ट्रासाउंड उठाते आप, दिखाते ना वे इमरजेंसी दिखाई गई है, और आप भी इमरजेंसी के प्रोटोकॉल्स को फॉलो करते.
आई डोंट नो, उन्होंने प्रोटोकॉल तो फॉलो किया है, बीपी देखा है, पल्स देखा है, उनको सब कुछ ठीक मिला है, बट पेशेंट इज नॉट रिस्पॉन्डिंग. बेसिक when you not responding, they thought ectopic pregnancy, now they did ultrasound and they caught by the authority. That is a case from one state, that's why told by my colleague, that's why I raised this question over here.
किसी नोडल अथॉरिटी को बोला जा सकता है कि हमें एक ऐसा हेल्पलाइन नंबर दे दिया जाए, where we notify the patient has come in emergency, we are doing ultrasound. आपको एक कोई अथॉरिटी, ये हम कर सकते हैं डिमांड. अब वो फोन नंबर्स उठाते नहीं है तो आपके पास कोई ऐसा मैसेजिंग वाला कोई आ जाए, पेशेंट इन अ कोलैप्स सिचुएशन, वी आर डूइंग द अल्ट्रासाउंड विदाउट फॉल्ट. सो ऐसा करके कुछ होना चाहिए.
Thank you all. Dr. Prabhjot, please give a vote of thanks.
Yeah.
Just before you finish, Dr. Manju, I would really like to thank you for arranging a very wonderful webinar, a very informative webinar. I also would like to thank Radhika Thapar ji for a very, very informative talk. And I really feel that you are the lawyer for all ART doctors. You are just the right person. We can look forward to you for all the support and help. And you are the person who can help you can help the doctors in India. Even there are a lot of changes need to be brought in this ART law. Yeah. Because doctors need to be less stressed out. We need to invite more medical tourism. All of us need to be attached to lawyers like you. And I just want to make a little request, Radhika ji. That can you help us file an RTI through ISAR or any of the organizations, that I would like the government to give us a very clear guideline about filling these F form or E form or these forms, whether they are if they are really necessary, then they should be uniformly implemented all throughout India. Because in these forms they are repeatedly writing what report did you give, which genetic laboratory did you send the test for, so what is the report, and we are just writing no report sent, no sample given. It's so
डिस्पैरिटी के साथ साथ प्रोसेस तो वही है ना ऑल अक्रॉस इंडिया में. मेडिकल प्रोसेस तो वैसे ही होता है. तो अगर फॉलिकुलर मॉनिटरिंग में एक स्टेट कह रही है फॉर्म भरो, दूसरी कह रही है बिल्कुल नहीं भरना, व्हाई इज दैट डिस्पैरिटी? उस स्टेट के डॉक्टरों से आपको डर है, इस स्टेट के डॉक्टरों से आपको डर नहीं है, या वो वाला मेडिकल फ्रेटर्निटी या जो लोकल अथॉरिटी है वो समझती है फॉलिकुलर मॉनिटरिंग से सेक्स डिटर्मिनेंट हो सकता है, गुजरात वाली सोच रही है फॉलिकुलर मॉनिटरिंग से नहीं डिटर्मिन हो सकता. सो मतलब आपके मेडिकल अफसर जो ग्राउंड लेवल पे है उनको ही नहीं मालूम बेसिक चीजें. अगर हो सकता है डिटर्मिन तो फिर पूरे पैन इंडिया में फॉर्म एफ लगाओ, अगर नहीं हो सकता है तो पूरे पैन इंडिया से एफ हटाओ, बिकॉज डॉक्टर की मतलब अननेसेसरी वर्कलोड तो मत डालो ना ऑफ डॉक्यूमेंटेशन जिसका कोई रेलेवेंसी नहीं है. यू आर बर्डनिंग द सिस्टम, यू आर बर्डनिंग द डॉक्टर्स, यू आर बर्डनिंग द ट्रीज. ठीक है. सो दीज काइंड ऑफ थिंग्स ऑन अ वेरी साइंटिफिक नोट वी कैन प्रिपेयर अ गुड PCPndt if there is something, and we can put it forward to the ministry.
Okay. Thank you very much. I really thank you on behalf of ISAR Haryana. Thank you very much for enlightening everyone.
Yeah, that's been very kind of you with such kind words. Yes.
Thank you, Dr. Nirmal Bhasin. Thank you, Dr. Manjunath. Thank you, Dr. Shalini. They have joined us and given us their precious time to us. Yeah. And they gave the valuable input, and that will help all of us in the future in managing the patients. And thank you, Radhika. Thank you, Dr. Prabhjot. Thanks to all panelists. Thank you, Dr. Jyoti, Meenu, Lakshmi, all. Thank you.
Yeah, thank you everyone. Okay, bye-bye.
Any comments from any comments from Dr. Nirmal Bhasin? Dr. Manju, please request Dr. Nirmal Bhasin to give some comments before she leaves.
Yes, ma'am. I gave the comments in that case that gynecologist registered level 1 ART center. Dr. Nirmal Bhasin is there. Ma'am, are you here?
I think she's left.
She left.
Yes, she's left.
Yeah, she left. Dr.
Thank
Shalini.
you, Dr. Manju.
Thank you so much.
Thank you, Dr. Manju, Dr. Rakhi, for such a nice panel. I think that questions were very tricky and the situations were very tricky situations. Very well made panel. Thank you so much. Thank you.
I'd like to thank everyone from Jagsonpal. My Sakhi is our CSR initiative. And to know more about this CSR initiative, you can log into our website, mysakhi.in. This session today was brought to you by Cystilia M, MEMUP, and Lycored M, brought to you by NAARI division of Jagsonpal. This is the QR code which can be scanned to reach the website. The recording will be available on our YouTube channel, Jagsonpal Medical Insights. I'll be sharing the recording in your WhatsApp, the group that has been formed for this temporary group. I'll be sharing it there also. Just like to tell you a little bit about the My Sakhi CSR initiative of Jagsonpal. This is for spreading public awareness about women's health and wellness from all life stages, from adolescence till menopause. And besides spreading awareness, the company has also made a positive impact by building sanitation facilities in government schools for girls, and also promoting women's health and hygiene seminars for these girls. Apart from this, we also have a My Sakhi medicine donation camp that also I will be sharing in your group. If anybody is interested to receive medicine donation from My Sakhi for the needy, for charity purposes, then that also can be availed. So we invite you to join us in our pursuit to spread awareness and promote better health management for women. Thank you all so very much for joining in today.